guys. First of all, to begin, Assalamu alaikum, I'm Lotus Maarouf. I'm a current third-year medical student, and alongside my colleague, who's another third-year medical student, Ashaz, we will be giving you guys the lung anatomy crash course. Now, the thing about lung anatomy is it's very easy, and just one tip, since your guys' CVP exam is upcoming, is please make sure to be really good with anatomy, embryology, and histology, because those are the easier disciplines, and you want to give more leeway for mistakes with physiology because sometimes it could get tricky, especially with Dr. Shams's questions. But inshallah khair, we'll begin. And first of all, we're going to begin with the lecture for intercostal spaces. Now, this is our first concept when it comes to intercostal space, is going to be, okay, I want you to imagine now the two ribs. You're going to have here the rib above and here the rib below. Now, I have 3 layers of muscles in between those 2 ribs. Now, what do I care about? I care about the structures that are running within these muscles. Now, we'll be discussing the shape or the orientation of the muscle fibers separately, but for now, I want you to be interested in how many layers we have and what structures are running between those layers. So first of all, we're going to have the external intercostal. Again, it's called intercostal because it's within the costal. Costal means rib. So it's within 2 ribs. This is going to be our first layer, and that's going to be known as our external intercostal muscle. Now, the second layer that we're going to be going through is going to be the internal intercostal muscle. Internal. So again, we have external, means outside, and the internal. Now, what do you think would be under the internal? From your guys' knowledge, from what you have taken before. Innermost, exactly. Malish, I've not noticed the chat, but if you guys could open your mics, you're free to do so. That would be better even. So we have an innermost. Now, the thing about the internal and the innermost is that they're very similar within the fiber orientation. But another thing that I want you to take care of is going to be that they sandwich structures. Specifically, they sandwich 3 important structures: my vein, my artery, and my nerve. My intercostal artery, my intercostal vein, and my intercostal nerve. The order that they're within is important. Van is an easy way to remember how they run, is it's going to be within the costal groove of my rib. So as you guys know from previous thorax anatomy, is that we have our costal groove, which is going to be at the inner side of my rib, and it's going to house my 3 structures, which is going to be my vein, my artery, and my nerve. Why does this matter? Is because I want to see what is the lowermost structure, is going to be the nerve, right? This matters to me with 2 conditions. When I want to block this nerve, which means I don't want it to feel from this area anymore. And the second thing that I'm worried about is in case I were to have any sort of injury to this intercostal space, what structure would be most affected? So what would you guys say it is? What structure is most vulnerable to injury, knowing the orientation? The nerve, exactly, the nerve. Now, the second thing that I want you to pay attention to is going to be the collateral intercostal nerve, artery, and vein. Now, from their name is going to be collateral, which means that they're just branches or tiny baby branches from the main branch. Do we really care about those? Not really. Another thing here is going to be the posterior intercostal artery. Dr. Olena didn't really focus on it, but just as you guys know, again, from your thorax anatomy, is the posterior intercostal artery is going to be running from the posterior side, and somewhere posterior lateral, it's going to meet with my anterior intercostal artery, and they're going to anastomose. Now, why is it the one most vulnerable to injury? It has to do with what's the most common site of injury? So what's the most common site of injury of the thorax from your previous knowledge? And if you don't know, it's fine, we'll cover it. The angle, exactly, or maybe the arc or the lateral side. So this is basically where my posterior intercostal artery would be running, which is why it's also vulnerable for fracture, for injury, alongside my intercostal nerve, because the intercostal nerve is not really housed by this intercostal groove, which means that if any penetrating trauma or any sort of injury were to happen, it would be most vulnerable. Now, again, we've slightly touched upon it, but we'll be discussing the concept of a nerve block. Now, local anesthetic, what is local anesthetic? So from its name, local, because it's at the site of the nerve, and anesthesia, which means what? I want to block the function, or I want to block the sensation. I don't want to feel from this nerve anymore. Why would I need to do that? Ashaz will cover it, but in maybe procedures like thoracocentesis, where I want to take a bit of aspirate from my lung or my pleural space, I'm going to need to have anesthesia for this. I don't want the patient to be in pain. So this is the function of my local anesthetic. Now, the way it works is I want to inject this anesthetic or this drug essentially around the nerve, not in the nerve. I used to think that back in first year, but in the nerve would paralyze it. No, you'd want it around the nerve in the surrounding area to stop its function. Now, where would I want to, first of all, location, where would I want to put this local anesthetic is going to be from the paravertebral line all the way to the area of required anesthetic. What does this mean? This means that, okay, this is my vertebra, right? My vertebral column. Beside it is going to be the paravertebral line. So I'm going to start from there. This is going to be the area where I'm going to start my block from, all the way to the area where I need to do the anesthesia. So maybe till I reach the injury or till I reach the site where I want to do this thoracocentesis or this specific procedure. Make sense? Understood? Okay, perfect. Now, what about when I want to inject the needle itself? Where would I want to put it? Would I want to put it, like, from your knowledge, again, from the anatomy? And we said that it's the three structures, how they're housed with the intercostal groove. Where would I want to insert the needle to avoid injuring it? Guys. Okay, it's basically in the middle between the two ribs. So maybe I didn't make myself clear, but basically when I want to, okay, now I've located where I want to put this anesthetic from my paravertebral line all the way to the area where I'm interested in blocking or in anesthetizing, basically either for the procedure or because I have some sort of injury. Now, when it comes to where I want to put the needle exactly, because again, local anesthetic, I want to insert a needle to fuse this or infuse this drug surrounding the nerve. Okay, so where would I want to put it? First of all, let's say that this is the area that I'm interested in anesthetizing. And again, remember that the neurovascular bundle, how it runs van. So nerve is the most vulnerable for being injured, which is why I want to go middle of this intercostal space to avoid hitting it, but also for me to be able to infuse this drug or like infiltrate it enough for the nerve to be blocked. Now, two things that are important is how it differs in adults and children. This wasn't in your slide, but she discussed it in the lecture. So for completion's sake, it differs in adults and children. Why? Again, you want it to be in between the two ribs. But what's important is that in adults, I want to put it in the middle so that I don't risk touching the collaterals or my intercostal nerve. So again, I'm staying away. I'm putting enough anesthetic to block, but also I'm not injuring it. I'm not injuring the intercostal nerve. But another thing that I want to take care of is children. Now, for children, I'd go even lower. I wouldn't insert the needle in the middle. I'd go even lower. Why would this matter? Is because in children, their ribs are tinier and the intercostal groove hasn't really become really deep and it's not really housing the structures as much. So now I'm not only having the fear of injuring my nerve, but I'm also having the fear of injuring my artery and my vein. Because again, the intercostal groove is not very deep. It's kind of shallow in childhood, which is why I'd want to go even lower, a bit lower than the middle. Now, you might be telling me, I have the collateral branches. Wouldn't I be scared of injuring those if I go a bit lower? The thing about collateral branches is, again, they're tiny branches from the main branch, so we don't really worry as much. Yani, the risk of injuring the intercostal nerve is greater and more important, so this is why we typically go a bit lower. Make sense? Okay. And just for your knowledge, so in words, if you were to see it in an MCQ, is you'd insert the needle at the lower margin of the rib you're interested in, but superior to the superior margin of the next rib. Make sense? So this is going to be the superior margin of the next rib, and this is going to be the inferior margin of the original rib. This is going to be where I want to put the anesthetic. Make sense? I hope I didn't confuse you guys. Okay, we're gonna move on. All right. So a bit of a checkpoint. I told you guys how they'd possibly phrase it in MCQ, and which one was it? Which of the choices? A. What else? Okay. Everyone agrees it's A? B, okay. Okay, let's check. Okay, so it's actually B. You guys are right. Now, why is it not A? Above the superior border of the ribs anteriorly. First of all, why would I want to go anterior? I wouldn't need to do that. And again, what's important here is going to be inferior border of the ribs. They really want to test you on your understanding of how it's housed underneath or at the inferior border of the ribs. Why? Because that's where I'm housing my neurovascular bundle. Okay? Does this make sense why it's not A? Yep, above the superior border is going to be the collateral. And again, we don't really care about the collateral, especially in children's. What I really care about is going to be inserting the needle in the middle, again, beneath the inferior border of the ribs, making sure that I'm avoiding the nerves that's going to be housed or not housed by the intercostal groove. Make sense? I hope this makes sense. Okay. Now, the next is going to be my intercostal muscles and the fiber orientation. Now, this was not really a mnemonic or a tip that was given for you guys, or it might have been, but usually it was given in previous years because this was something that was also common for the fiber orientation of the abdominal muscles or the muscles of the abdominal cavity. So the fiber orientation of the intercostal muscle matters because, again, we'll see it towards the end of the lecture. It matters because this will help either elevate my ribs or move them in specific directions for me to increase the size of the thoracic cavity to allow my lungs to expand and fill with air. Now, again, we've said we have three muscle layers, which are, again, I'm assuming you guys are saying external, internal, and the innermost muscle layers. Now, for the external intercostal muscle, it's going to be the most different out of them when it comes to fiber orientation. This fiber orientation is known as oblique, as you guys may have taken in FND. And the way I want you to remember the fiber orientation is going to be hand in pocket direction, which means, again, how are you putting your hand in your pocket? This direction, right? So again, imagine you have pockets and you're putting in your hand. This is going to be hand in pocket direction, and it's going to be the direction of the external intercostal muscle. Another way they might describe it for you is extending from the posterior rib tubercle all the way to the ribs, or all the way anteriorly to the sternum. It's a more confusing wording, but again, all you need to know is hand in pocket direction, which means it's going to be obliquely down. Now, what about the internal intercostal and innermost intercostal? Now, those have a similar or the same fiber direction, and it's going to be hand on chest. So the way you put your hands on your chest, this is going to be the fiber direction. Hand in pocket, hands on chest. So this is going to be the difference between the fiber orientation. Now, another thing that you'd see is that the fiber orientation has to do with movement, which tells me that my internal and my innermost intercostal muscles do the same movement, or are, because they have the same fiber orientation, this means that they make the same muscle movement. So for my external intercostal muscles, again, hand in pocket direction. So this means that it's going to be going from this rib all the way to this rib. Imagine it contracting. So what is it doing? It's going to be elevating, right? So it's basically going to be elevating the ribs outward. And this is going to be the function of my external intercostal muscle, which means that it's a muscle of what? Inspiration or expiration? Inspiration, exactly. So it's pulling, it's going to allow for the increase in the size of the thoracic cavity. And again, it's in hand and pocket direction, pulling the ribs up, which means I'm allowing for inspiration. Now for, again, hands on chest, think of it as someone pressing down. So what is it? What is it responsible for? Inspiration or expiration? Expiration, exactly. So I'm pressing on my chest. This is going to be the direction by which they contract. It's pressing on the chest, which means that what? It's causing expiration. Again, this is everything we've said, but just as a quick review, the external intercostal muscles are going to, again, as I told you, the wording is going to be extending from the rib tubercle posteriorly. So posteriorly from the rib tubercle, that's where I'm starting. And then I'm going extending anteriorly into my sternum, okay? This way. Again, just remember hand in pocket, it's much easier. Now for internal intercostal, and again, hands on chest, so this is the way. So it's going to extend from the sternum, so from the sternum anteriorly, and then it's going to go all the way posteriorly. And again, recall that the internal and innermost are not only similar in fiber orientation, which is going to be the hands on chest direction, but it's also similar in function, which means that it's pressing on my chest, it's allowing for expiration. And again, most important, and I'm not sure if I've explicitly stated it, but sandwiched between what? What are the two layers that are sandwiching my van, which is going to be under my costal groove? Internal and innermost, exactly. So they're similar, they sandwich the neurovascular bundle. Everything about them is the same. And again, remember that when you want to put the anesthesia, you want to put it at the inferior border of the rib, okay? Don't mistake it and put superior to the rib, okay? Everything makes sense? Now we move to our next concept. Okay, and this video is going to be of a pathology which is known as flail chest or stoven chest. Now, this is going to be applying all the anatomy that we've discussed so far into an injury. So let's say that someone, again, what's the most common site of fracture? You said the lateral chest wall or the arc of the ribs. Let's say someone punched me into my chest wall and I broke multiple ribs, not just one, multiple. Now, the thing about this is that it's not supported by anything anymore. The bone is not supporting it with the entirety of the thorax or the chest cavity, which means that this piece of bone, multiple pieces of bone, that are broken, the multiple ribs, are going to stay in place. This is something that people often mistaken, but they don't move, they stay in place, which will cause a paradoxical respiration. Why? Because it looks like it's breathing in opposite to the normal breathing. What does this mean? So this means that when I'm breathing in, rather than the entire chest wall expanding, it goes in. So an easy way to remember it is the loose segment is going to be inward on inspiration and outward on expiration. This looks like it's moving inward, but it's not moving inward. It's simply staying in place, which is why it will cause paradoxical respiration. So again, the loose fragment, multiple rib fractures, someone has fractured the ribs on multiple ribs, not just one. The loose fragment will stay in place, but when I'm starting to breathe in and out, when I breathe in, rather than it expanding with the entire chest wall, it's going to stay in place and cause an inward shape, inward on inspiration. Make sense? Okay, hopefully it makes sense. Now, for flail chest, one keyword that you might see and might help you with solving MCQ is going to be painful injury. Some choices you'll find, first of all, they're outright wrong. It's very easy to like eliminate them. But one thing that you'll see is painless. Obviously, it's not going to be painless. It's going to be an extremely painful injury. Now, another thing is a question for you guys. What's the most feared complication? Now, obviously, as you guys can see here, the sentence is saying it will affect the blood oxygenation, it will cause respiratory failure, all of that. But at the moment, what I'm most worried about, and why do I need to fix this flail chest ASAP? Puncture of the lung, exactly. So I'm really worried about puncturing the lung because, again, imagine when I'm expanding, it's collapsing on my lung. It's going inward when I'm inspiring. So this means that the borders of the sharp rib might puncture my lung. No, and again, you guys answered this. What's the most common side? It's going to be the lateral or posterior lateral or basically the arc of the rib. Make sense? Hopefully it does. Okay. Yalla, answer. A, okay. Does anyone have any different answers? Okay, everyone says inward on inspiration. Exactly, very easy to remember. inward on inspiration. And you guys know, obviously, what's the normal movement of the chest wall with inhalation and expiration. Okay. Why is the photo not showing? اللي هو my diaphragm. Hold on, let me make sure. Yeah, you can see it here. So the diaphragm basically has three parts. You guys know what the diaphragm is, or hopefully by now you guys know what the diaphragm is. It's going to be the muscle that's responsible primarily for my inhalation. Okay. Now, the thing about it is that it separates two compartments of the body. What are they? The two compartments? Very easy question. Let's say you guys answered, it will separate my thorax, exactly, my thorax from my abdomen. So I have my abdominal cavity and here I have my thorax. So this is going to be the separation between them. Now, the muscle of the diaphragm, I want you to think of it as multiple sheets of muscle converging together because, right, it's a big muscle, but it's multiple like sheets of fibers. It has three parts. So these three parts have to do where it's attaching. So first of all, I'm going to start with the sternal part. The sternal part, from its name, it's sternal, so it's going to be posterior to my xiphoid process. So if I were to go from the posterior side of my xiphoid, what? You guys can see my web browser. Yeah, because it's not showing, the picture isn't showing with the presenter mode. I'll go back to presenter mode. خلاص عوافي, look at my web browser. Anyways, from the posterior side, no, it's okay. From the posterior side of my xiphoid process, this is going to be, so this is going to be the sternal part of my diaphragm. Now for the costal part, specifically, when I'm looking at the lower 6 ribs, so again, how many ribs do we have total? 12. At the lower 6 ribs, I'm going to be inserting the costal part again from the inner side. This image is going to be the orientation if I were to flip someone from down. I'm looking at their diaphragm من تحت هيك. And then I'm going to have the vertebral part. It's going to be attaching to the vertebral body, specifically the lumbar, because beyond the lumbar vertebral column, خلاص, I'm looking at the abdominal cavity, no longer the thorax. And it's going to be attaching there. Now, the way it's attaching is by a ligament known as an arcuate ligament. And it's basically, arcuate means arch. And it's going to be just these arches that are attaching. Now, why do I care about these parts? Is because all of them will go and fuse into a central part known as the central part of the diaphragm. Furthermore, why do I care about dividing the diaphragm into multiple parts? Is because different parts of the diaphragm will be innervated differently, okay? Makes sense so far? Hold on, where's the chat? Okay. طيب, we'll move on to the next part. Okay. Now, for the central tendon, and again, I told you guys how it's formed. How is the central tendon formed? Okay, so basically it's formed by the fusion of all of the three parts of the diaphragm. So all of them will go from their different attachment sites and converge at the dome at the top into a central tendon, okay? And it's known as a clover-leaf shaped tendon, all of that. Now, the superior part, or this specific tendon, is going to be known as an aponeurosis. It's a type of tendon. So it's basically a long sheet of tendon. Now, the thing about it is that it's continuous with the pericardium, specifically the fibrous pericardium. You guys recall from your anatomy lectures for cardio is that there's two parts of the pericardium, the serous and the fibrous. The fibrinous will fuse with the central part of the diaphragm, which explains why the entire movement of my chest is very synchronized and within like one unit. You don't have the heart flopping around, okay? Now, next is going to be a very important concept. You guys will 100% be asked about this in your MCQ, and 90% sure you will be asked about this in your OSPI. Now, the picture in your slides was of the real cadaver, but I wanted to get you guys this picture because it's cartoonish, a bit easier to follow. So we have in the diaphragm, again, we've said that it has three parts. A part that's going to be from the xiphoid process, or the posterior side of it, that's going to be the sternal part. a part that's going to be from the lower 6 ribs, which is going to be my costal part, and a part, Allahumma salli ala nabi, one from the vertebral side, which is going to be from my lumbar vertebral bodies, attaching by the arcuate ligaments, and again, attaching to my vertebral column. Now, the diaphragm itself, again, it's sheets. It's not one continuous muscle. It has hiatus. Hiatus means an opening or a discontinuation. 3 that are important. And again, how do we identify them is based on the vertebral level. So recall that the thoracic cavity is in the thorax. So all of these hiatus will be at the level of what? The thorax. 3 levels. So the first is going to be my vena cava hiatus, and it's going to have a good way to remember it is it's going to have all the structures that are typically on the right. So I'm going to have what's on the right? My vena cava, okay? And it's going to have my right phrenic nerve. Makes sense so far? For the esophageal hiatus, it's going to contain my esophagus and my vagus nerve, and it's going to be at level T10. And again, recall that the vagus nerve is going to be what? I don't know if you guys have taken this, but it will go and form a plexus around the esophagus, or basically hug the esophagus all the way till it exits the esophageal hiatus, and then it's going to go and form its branches to supply the rest of the abdominal contents or the abdominal organs. Now, for the aortic hiatus, it's going to contain my aorta, thoracic duct, and azygous vein. Make sense so far? Guys, this is very, very important. You must memorize all of these, and the levels, very important. Some way or another, they'll ask you about it. And, okay. Next is going to be, I want you guys to identify this on the cadaver. And I'll give you easy ways after to identify everything. What's each level? Okay, what's it? What's the level and what are the structures that pass by? T8, T10, and T12, yep. And again, know which one is going to be for what. So T8 is going to be for my vena cava, T8 is going to be my esophagus, and the aorta is going to be T12. And again, it's not going to be just these structures. Some other structures will be passing by with them, okay? Hello, what is this? And what level is this? IVC T8, طيب, وthis? Okay, we'll skip it. This one. Oh, esophagus theta. Okay, this one. We'll answer. Okay, aorta T12. Exactly. So again, it's not showing. So I'm going to go and look at my browser again. The first one is going to be T8, which is going to be my IVC. What's coming with it is going to be my right phrenic nerve. Now, why is this? Again, recall that all of these pictures are going to be flipped. It's not the aorta. This one is IVC. And how can you tell this? Do you see this? This is going to be like an imprint of the heart. And it's going to, I'm looking at the inferior surface because recall we're looking here at the diaphragm and عم بطلع من تحت. I'm looking at the inferior surface of the diaphragm, and here I have the imprint of the heart. This is going to be the IVC. And what's passing with the IVC is going to be the right phrenic nerve. Now, one thing about the esophagus is that it sandwiches the aorta. How does it sandwich the aorta? I have my vertebra here, most posterior. So right here is going to be most posterior is going to be the vertebra. Anterior to it is going to be aorta. Anterior to it even more is going to be the esophagus. So the esophagus and the vertebra are sandwiching the aorta. So this way, I could tell this is the aorta, this is the esophagus. How can I tell this is the esophagus? Another way is it's going to be very muscular. It's a smooth muscle organ. It's not patent like the aorta. Does this make sense? This is an inferior, it's an inferior view. Inferior. You can see this is the bottom of the lungs. This is as if I'm looking, this is the same view as this. So I'm looking at the person from here down. I don't know if you can see. Makes sense? So this, if I were to tilt them a little bit more down, you can see like inferior surface. Make sense? خلاص, okay. Alhamdulillah. طيب, for esophagus, again, recall that it will have the left vagus nerve with it and the left gastric vessels. And for T12, it will transmit the descending aorta. And again, be careful of descending aorta because I don't know what they could change in the MCQ. Thoracic duct and azygous vein. And again, as you guys remember, the azygous vein is going to be on what? Left or right side from your thorax anatomy? Right, exactly. Okay. Right? Right or left? That way. Hold on, I'm confused. No. It's yeah, the vena cava is I'm not sure what I said, but I think لخبطكم بالdirections. But again, recall that the vena cava is on the one sec. Let me make sure. I got yeah, so sorry guys. أنا لخبطكم. The IVC is on the right. All of this is on the right. All of this is on the right. And the wait, hold on. I'm confused. What's the confusion, guys? IVC is on the right. Azygous vein is on the left, I believe, with the aorta. I'll make sure and get back to you guys when I'm reviewing the second lecture. I'll make sure of this point, but I'm pretty sure that the IVC is going to be on the right and the aorta is on the left alongside the azygous vein. Okay? Yep, it's with the aorta, yeah. I'll make sure. I'll double check, but I'm pretty sure what I said right now is correct. I'll double check. We'll let you guys know in the second lecture. So now for the phrenic nerve. The phrenic nerve is very important when it comes to the lungs, and it is a mixed nerve. This is important to know. What does this mean? This means that it will have motor innervation and sensory innervation. Now, first of all, we're going to orient ourselves with where this phrenic nerve is. So first of all, it's going to arise from level C3 to C5. So again, I have my spinal cord posteriorly, and it's going to have my C3, C5, C4, C5 nerves coming out, and it's going to go anteriorly, and it's going to go anterior to the scalene muscle. Pretty much sure you guys don't know what a scalene muscle is, but it's just a muscle of the neck, which means it will go anterior to the neck like that, and it will form two straps like this in the thoracic cavity. Now, one thing about the phrenic nerve is دايما recall, especially in your OSPE, when you're looking at the cadavers, is that the phrenic nerve is anterior. For the vagus, it's very posterior. You're not going to see it like outright unless they really dissected. So the phrenic nerve is anterior, and the vagus nerve is more posterior. Now, specifically where within the thoracic cavity is, I want you guys to look here, and again, you guys will learn more about the opening of the lung. This is going to be the opening of the lung. You guys will learn it more with Ashaz, but in relation to it, the phrenic is anterior and the vagus is posterior. The vagus is posterior, and again, recall what was also posterior, and it's hugging what? Hold on, let me open the chat. What was it hugging, and what's posterior? Esophagus, exactly. So the esophagus is very posterior, and it's going to have the vagus running with it. The phrenic is going to be anterior to all of this as two straps. And again, where was the phrenic nerve? Which hiatus? The right phrenic nerve. What was it passing with? IVC, exactly. IVC on the right. Okay. I think we didn't miss anything. Okay. Now for the actual innervation, we've set the location of the phrenic nerve, how it runs. Now, what about its function? For motor, the motor part of the phrenic nerve is to innervate the diaphragm. Okay? Makes sense so far? So C3, C4, C5 is going to be motor phrenic to the diaphragm. Okay? The diaphragm is completely innervated by the phrenic nerve. Now, when we're talking about sensory innervation, it's a bit of a different story. I have more than the phrenic nerve. The phrenic nerve, again, recall, how is it running? It's running as two straps anteriorly. It's very close by to the top part of the diaphragm, which means I can innervate sensory. Now we're talking about sensory innervation. It's very easy to innervate the top part of the diaphragm. But when I'm talking about the lower six, or again, if you recall, the costal part of the diaphragm, where it attaches to the lower six ribs, it's a bit far from the anterior surface of the phrenic nerve, right? So the phrenic nerve won't give innervation there. What will give innervation there? What's running with the ribs that could give sensory innervation to my diaphragm? The costal part of the diaphragm. Intercostal nerve, exactly. So the lower six intercostal nerves will innervate this costal part of the diaphragm. Again, central sensory innervation will be by phrenic. Lower six ribs, or the costal part of the diaphragm, is going to be by the lower six intercostal nerves. Now, what about motor? What supplies the diaphragm? Fee more than one nerve? Only phrenic, only phrenic. And where does the phrenic arise from? Or what's the root of the phrenic? C3, C4, C5. Very important to know. This is where the phrenic nerve will arise from. It will give complete motor innervation to my diaphragm and sensory innervation only to the central part of my diaphragm. And the lower six intercostal nerves will give sensory supply to the costal part of my diaphragm. Okay? طيب. Now, we've spoken about the diaphragm, we've spoken about how it attaches, the hiatus that it contains, and we're now going to talk about how it aids inspiration. Now, the diaphragm, again, is a muscle. I get motor innervation from my nerve, my phrenic nerve, completely. Now, when I want to get my diaphragm to move, I will flatten it. So normally, the normal orientation of a diaphragm is going to be curved. When I want to take in a deep breath, the diaphragm will flatten, which means when it contracts, will it curve or flatten? Contraction. I'm activating it. Flatten, exactly, flatten. What's underneath? Again, what did we say that the diaphragm will separate? Two cavities. Thoracic and abdomen, which means what is it pushing on? What's underneath it? What's it pushing on? The abdominal cavity, exactly. So it's going to be pushing on my abdominal organs to increase the vertical diameter of the thorax. What does this mean? Vertical diameter means the height. So this means this. So when the diaphragm is flattening, I'm increasing this, the height. The height surface, or the height cavity of the thorax. I hope this made sense. Now, when I'm increasing this vertical diameter, I'm going to cause for a decreased intrathoracic pressure. You guys will learn more about this in your physiology, but negative pressure in my lungs, or increasing this vertical diameter, will cause negative pressure, and negative pressure sucks, which means خلاص, I can get the air inside the lungs, okay? And this is how I can expand the lungs. Make sense? Yep, okay. Now, this is going to be just a bit of a review for your guys' knowledge, yani for the functions of a phrenic nerve. And now we're going to apply clinically everything that we found out about the diaphragm into a clinical concept. So, can I paralyze both sides of the diaphragm? And how could I do that? Paralysis means I can't move it. Yes, okay, yes. So we can paralyze both. Yep, exactly. Damage to the phrenic nerves. So let's say it's a very funny situation. I don't know how it could happen, but let's say we cut both of these two phrenic nerves. What will happen? Complete paralysis. What will happen to the patient? We won't even get to see what will happen to them because they'll die. خلاص. You can't flatten your diaphragm. خلاص, the patient's dead. Now, we could have half paralysis of the diaphragm. And again, if I have complete paralysis means I kill both of the phrenic nerves. Half paralysis means I kill one nerve. Now, if I have hemiparalysis or half paralysis of the diaphragm, would the diaphragm, the affected side, when I'm breathing in, now I'm inspiring, would the affected side be flat or curved? Curved, exactly. This is very important, curved, which means that while one side is being able to flatten, the other side is still curved. And again, this will cause a paradoxical movement, which means that what the injured side is having abdominal content pushing on it. Instead of like pushing on the abdominal content, now the abdominal organs are pushing on the diaphragm. Okay? That made sense? Okay. Next. Another thing. Now we've spoken about the paralysis of the diaphragm, and we said that if I were to have one side of the diaphragm, which means I affected one side or one phrenic nerve, I will have one side when I'm inhaling, it's going to be curved, and all of the abdominal organs are going to go and push on the side that's affected or the side that's paralyzed. Now, what if I were to have a rupture of the diaphragm? Again, I want to re-emphasize, what's the most common location of a thoracic wall injury? Rib angle, exactly. Rib angle or laterally. Now, another thing I want to increase to the story is going to be which side is more dangerous or which side is more likely to be injured generally. I'm talking about injuries in general, is going to be the left side. Now, the reason why is because I have on the right side what in the abdominal cavity a very giant organ, which is going to be my liver. The liver is very dense. Let's say that someone were to punch me or I were to go into a car accident where the steering wheel hit my thorax. I have the very big liver protecting kind of the area. So this means that the likelihood of me rupturing my diaphragm is not very high. But for the left side, I only have the spleen. Yani it's very small organ, nothing is protecting it. So if I were to have any blunt trauma to my left side, I'm 100% going to be rupturing my diaphragm on the left side. Now, what would happen if I were to rupture my diaphragm? خلاص, I'm discontinuing it. There's nothing between the thorax and the abdomen. What will happen? It's in the picture. Exactly. Stomach will go up. Or basically, all of the abdominal organs are going to go and travel into my thoracic cavity. What's something I'm fearing from this? Why would this be really bad? What could this do to my lungs? And again, it's in the picture, yani. Compression, exactly. So I'm really worried now about compressing my lung. It can't expand. خلاص, the abdominal organs are going somewhere where they can't be. It's compressing on my lung, okay? I don't think I missed anything. And again, often at the posterior lateral aspect of the diaphragm. Okay. Complication, you guys have mentioned it, is going to be collapsed lung. Now, we're going to pull everything together. This is going to be the last concept, and then Ashaz will complete with discussing the anatomy of the actual lungs and the pleura. And we're going to just mention the muscles of inspiration, expiration, how they move, how they control the movement of the cavity. So first of all, muscles of inspiration. After everything we've discussed, what are they? Diaphragm and okay, diaphragm for inside, but external intercostal, exactly. So my diaphragm is going to flatten, and this will increase the vertical diameter, which will allow for me to create negative pressure in my lungs and to pull air inside. And for my external intercostal, again, how was it? It's hand in pocket direction. It's pulling on my ribs up and allowing for me to, again, increase the area inside my thoracic cavity. There's another muscle she has in her slides. She never mentioned it يعني, during the lecture recording. This is just the serratus posterior superior muscle. Do you need to know this? I highly doubt. You guys didn't take MSK. But basically, it's this muscle. Serratus. So that's the name because it's almost like the zigzag of, what do you call it? The serrating knife. Posterior because it's on the back. Superior because it's up. And muscle. Yeah, that's it. Now, what about the muscles of expiration? From everything we've discussed, innermost and internal. And what's in between them? Van, exactly. And where would I want to anesthetize if I needed to? In relation to the ribs? Middle, but specifically in relation to the ribs? Superior ولا inferior border? below the rib. Below the rib, yep, below the rib. And again, she added serratus posterior inferior, so you're called the serratus superior. Now this one is going to be the inferior. Both serratus muscles are important for inhalation and expiration. This is a very important point. Now, everything that we're discussing right now in relation to the muscles is assuming I'm telling the person or all of this process is happening actively, which means I'm actively taking in a breath and exhaling. I'm actively using all of these muscles. But normally, especially when it comes to, or only when it comes to expiration, recall one very specific quality you guys probably took in histology for the lungs. What is it? A very important quality of the lungs, recoil. The lungs are incredibly elastic, which means realistically, these muscles, sure, they're being used, but normally it's mostly the function of the recoil of the lungs. I'm not really using actively my rib cage. When would I actually use my rib cage? When am I actually activating all of these muscles? Is in case I were to be in respiratory distress, or I'm asthmatic, or I'm having someone chasing me down, I'm going to be using more muscles. I'm going to recruit more muscles. But normally, it's just the function of my lungs recoiling back into place. Now, obviously, for inhalation, the diaphragm is working. But for expiration, it's going to be the recoil of the lungs, okay? Again, we mentioned this. What if I'm asthmatic, stressed? What muscles would I use to breathe? It's going to be normal inhalation is going to be happening by the diaphragm and just simply, Allahumma, the recoil of the lungs. But if I were to start being stressed out right now, like actively, or I'm running, I'm asthmatic, I'm going to start recruiting more muscles. Now, are the muscles we mentioned the only muscles of inhalation and expiration? No. We have a bunch of accessory muscles. Sarah, I have no idea if you guys need to know all of these. When I see, I know it vibe. يعني, be familiar with them. But basically, the idea here is I start using the muscles of the abdominal cavity too. It's not just the thorax muscles. Now I'm using the muscles of the abdomen too to breathe in and out. Make sense? Hopefully makes sense. Anyways, now we're going to be discussing how the diameters of the lung or the thoracic cavity change in relation to inhalation and expiration. And again, we've low-key discussed all of this already. So for the vertical dimension, you guys should know this because I mentioned it a lot. What happens? Or how do we increase the vertical diameter? Diameter, whatever. Diaphragm contracts. So the diaphragm will flatten, and this will increase the height in the lungs. And this will cause for the compression of my thoracic viscera. I'm pushing everything in my abdomen down, and this will cause for the increase in the height of the lungs. Now, what about the anterior posterior dimension? And if in case you're having difficulty imagining it, it's basically from the sternum all the way to the back. So this diameter. What's responsible for increasing that? I mean, it's on the slide, بس يعني. Okay, the internal, external intercostal muscles. So again, hand in pocket direction, it's pulling the ribs up, and this is going to cause for the increase in this diameter right here. Now, what about the movement of the ribs at the costovertebral joints around the passing, blah, 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 blah. Hold on, we mentioned this. Okay, pump handle movement. So what's pump handle movement is going to be, again, Olina loves this, but it's basically the movement here, right here at the sternum. So it's going to be out and up, out and up. What's responsible for this is, again, it's just like the AP diameter. It's going to be what? The external intercostals. They will pull. And again, recall that they're anterior too. So they're pulling, when they're pulling, and I'm pulling the ribs up, and recall that the ribs are continuous with the sternum. And they're attached right beside the sternum. فأجباري, if I were to be contracting my ribs and allowing them to move up, they'll move the sternum with them. So the sternum will move out like a pump handle, this movement, and the ribs will move out, this movement. Okay? And then for the transverse dimension of the thorax, it's going to increase by the intercostal muscles contracting and the raising of the ribs. And again, we said this is the bucket handle movement, which is basically this. This is the bucket handle movement. And for transverse diameter, I'm talking about this. So this is going to be the bucket handle movement. Now, for the pump handle, it's going to be here, anterior, and it's going to be up and out at the sternum. by the external intercostals pulling the ribs, which pull the sternum, causes the pump handle movement, okay? That's my last question, and we're going to be done with the first lecture. A. Okay. Any other answers? Everyone agrees it's A? The diaphragm will contract, it will push the abdominal contents down, the ribs will move up and out, and increase the vertical and horizontal dimension of the thorax. That's it for the first lecture, and now you're going to learn more about lung anatomy with Ashaz.
Assalamu alaikum, everyone. Am I audible? Can you guys hear me? Hello? Hello, hello. Can you guys hear me?
Yes, we can hear you.
All right. So just share the screen. Assalamu alaikum, everyone. I'm Ashaz Sayeed. I'm also a third year medical student, and I'm going to be explaining the next two lectures. You have your lung anatomy and the anatomy of your pleura. All right. And just lock in with me. It's going to be an easy lecture. Both of them are going to be easy, inshallah. And just focus on what I repeat because that's what they ask a lot of times. All right. So, Bismillah, let's begin. So let's start with the basics of the lung. So most of the people, when they think about the respiratory system, they just say, oh, lungs. So actually you have your lungs, the tissue, the spongy tissue, which you see, and then you have your respiratory pathways. All right. All right. So again, respiratory system is your lungs, your spongy tissue, plus your respiratory pathways. All right. And another thing is you have to know the ventilation mechanism. Okay. So not only do you have your lungs for respiration, as my colleague Lotus mentioned, you also have your intercostal muscles, your diaphragm, the thoracic cage, all of these. These work in unison to help your lung expand and to allow air to enter your system. All right. So that's all the basic you need to know. Now, yeah, it looks like this. So you have your lung, and then surrounding it, you have your ribs, your diaphragm, yada yada. Now, let's discuss the windpipe. So you have your spongy tissue, that's your lung, and then you have windpipes which allow air to reach the lungs. First off, we'll start with the trachea. All right. Trachea is this part. This part right here, that's the trachea. And you have to know that it's around 10 to 13 centimeters long and 2.5 centimeter diameter. They won't ask this, just for general knowledge. All right. What you have to know is the trachea is made up of C-shaped hyaline cartilage. All right. So it's not a perfect tube. It's not a tube of cartilage. It's basically rings. So you have your first ring, your second ring, your third ring. So these rings are present. All right. And these are not completely circular. These are C-shaped. All right. And again, these are C-shaped rings. And the function of this arrangement is to maintain patency, which means if your trachea was a solid cartilage, like if it was like a solid tube of cartilage, what will happen with it's just gonna bend. It's gonna bend and it's gonna collapse. So this structure prevents that from happening. All right. Patency means the trachea remains open. And that's important because if it collapses, air will never reach the lungs. All right. So the borders, again, just remember C6 and then T4, T5, which means it's going to start from the cricoid cartilage. It's around here. This is your cricoid cartilage. From here to the sternal angle. So around here. All right. That's your trachea. Now, let's talk about the carina. The carina is just below the trachea. So you have the trachea and then you have the carina. After the carina, you're going to have your bronchi. All right. So a carina, when you check it from a camera, it's going to look like this. So these holes which you see right here, these are the right and the left primary bronchi. All right. And the carina itself is this flat wall-like ridge. All right. Again, trachea and then the carina and then the left and the right primary bronchi. And another thing you have to remember of this part, a clinical thing, just remember it, is that the surface of the carina is the most sensitive part and it's associated with the cough reflex, which means if any like dust particle of anything, if it hits there, you're just gonna start coughing and it's really sensitive, all right? And the other thing is if you see that instead of this being like this flat wall kind of thing, if it's widened, if it's changing shapes, it probably means you have something called bronchogenic carcinoma. I will discuss this further down the lecture, but just know this, all right? Two things you have to remember from this part is one, it's the most sensitive area and it's associated with the cough reflex. And the other thing is that if you see there's something wrong with the carina, it's bronchogenic carcinoma, all right? That's it. Now, let's talk about the right primary bronchus. All right, there's a difference between them. So this one right here, that's going to be the right primary bronchus. All right. This first point for both the right and the left, very, very important. They will ask you a question on this. All right. No, it's not left. All right. Because I'll show you 1 second. In the image, it might look like it's left, but it's actually right because you'll see that there's one division here, one division here, one division here. All right. So you have 3 divisions. I'll talk about it. First of all, the structure of the right bronchus itself is it's a short, it's wider, and it's more vertical. Okay. So you have let's say this is my left arm. So this represents the left bronchus. This is the right bronchus. The left bronchus goes more horizontal. All right. And the right bronchus goes, instead of going horizontal, it kind of goes vertical in this way. All right. And because of the structure of the right bronchus, it's shorter, first of all. It's going more vertical and it's wider. All right. It's wider, it's more vertical. So what happens if, let's say, a child inhales a foreign body or food or anything like that? It's because of gravity itself. Because of gravity, it's more probable for the object to get stuck in the right bronchus, just because the right bronchus is wider and it's more vertical. Got it? No, right is shorter. All right. Right is shorter. Right is shorter, it's wider, and it's more vertical. That's why foreign bodies can easily enter it. Just this is important. They will ask you a question on this. All right. So the right primary has 3 secondary bronchi. All right. And each of these secondary bronchi will supply 3 different lung lobes. Now I'll explain you guys later down what a lung lobe is. Okay, basically you basically have the entirety of the lung, and the whole lung is divided into 2 or 3 sections. The right lung is divided into 3 sections. These 3 sections are called lobes. Okay, for the left lung, it has 2 lobes. Now the right side, you're gonna have 3 secondary bronchi and 3 lobes. One secondary bronchi will go to the lobe, another one will go to another lobe, so on and so forth. All right. Another thing you have to know is the upper lobar bronchus. Okay, so you have your upper lobe, your middle lobe, and your lower lobe. So the bronchus, the secondary bronchus, which goes towards the upper lobe, is gonna be above the pulmonary artery. Okay, and every other secondary bronchus on the left side, on the right side, no matter what, all of them are gonna be below the pulmonary artery. Only the upper lobar bronchus is gonna be above. That's it. On the right side, the upper lobar bronchus. That's the only one which is gonna be above the pulmonary artery. All right. Now you have your left primary bronchus. Again, this one is longer. This one is longer. You can see it here, right here. You can see it right here. The right primary bronchus is, that's it. That's your right primary bronchus. Look at the cursor. And the left one, it goes all the way long. All right. It's pretty long. It has to take this turn. Okay. The right one is, that's it. From here, the secondary bronchi start. That's it. Short. Now, it's longer, it's narrower, and it's more horizontal. So the chances of anything getting stuck here are less because gravity works vertically. All right. You can see this. The thing falls here and just takes a natural route and it goes vertical. This one is more horizontal. Okay. It's not going to get past this. It's not going to get past it. It's just going to fall, keep falling like this. All right. Now, again, as I told you guys, the left lung has two lobes. Okay. It has two lobes, which means it has two secondary bronchi, each supplying the two different lobes of the left lung. I wrote right by mistake. It's a mistake, I'll correct it. Left lung, all right. Again, both secondary divisions are below. Now, we are done with the windpipes. Now we'll actually talk about the lungs, the spongy part, all right? It's also called pulmons, but I never heard anyone using that, all right? Okay, again, right lung, you have three lobes. This is the upper lobe, this one's the middle lobe, and this one's the lower lobe, all right? And it has two fissures. Fissures basically separate these lobes. So you have the horizontal fissure, you can see this one, it's more horizontal, okay? The horizontal fissure separates the upper and the middle, all right? And the oblique fissure separates the middle and the lower one. That's all about the right lung. And for the left lung, you're gonna have two lobes. This is your lobe one, that's your lobe two, separated by one slant line. That's the oblique fissure. And the most important thing is this thing. This thing. It has two names. One thing you can call it a cardiac notch. You can call it a lingula. It's the same thing. All right. Don't get confused. What this does is you know how the heart is somewhere around here, and just at the apex of it, it goes a bit towards the left. All right. So to accommodate for this deviation, for this part of the heart, which kind of goes in this way, you have the lingula. All right. Cardiac impression, I'm pretty sure it's the same. Okay, it's basically this kind of a space, just a minor space. It's a minor space. If you guys look at the cadaver, it's a really minor space. It's not going to be a huge bump in there. All right, it's just going to be a minor space, just enough for the heart's apex to fit. All right. So let's go here. Now these are just stay with me on the slide. This part is the apex. Apex any highest point. All right. So this is the highest point of the lung. Next, you have the hilum. The hilum is on the inside. It's not on the outside, it's on the inside, in the center. You have the inner surface of the lung right here. Okay. And then at the center, you have the hilum. And the hilum is where blood vessels and the bronchi, all of these structures enter from. It's basically like a doorway. All right. It's a doorway towards the lung. That's your hilum. Now you have your costal surface. Costal surface basically means the surface of the lung which is towards your ribs. Mediastinal surface is the exact opposite, is the surface towards your heart. So costal is the outer surface, mediastinal is your inner surface. All right. Now the base, it's also known as the diaphragmatic surface because this is the part which sticks to the diaphragm. All right. Now the cardiac notch, cardiac impression, lingula, all of these, same thing. Now inferior border is just like the lowest part of the lung, all right? So now we'll talk about the left lung. Again, it has two lobes, one fissure. All right. This is your upper lobe, this is your lower lobe, and this red line you see right here, that's the fissure which separates both. All right. Now, hilum, again, I told you guys, it's the entry point. It's like a doorway to the root of the lung. Now, this thing, highlighted yellow, that's the hilum. And what's the root? The root is your artery, your bronchus, and your vein. All right. Again, you have to remember the order. Like my colleague Lotus, she told you guys to remember the van thingy, right? Now here you have ABV for the left lung, and for the right lung, it's gonna be BAV. ABV, BAV. All right. Left lung, ABV. So look at the image here. The first thing you see, that's A. That's pulmonary artery. Okay, A. And then the next thing you're gonna see is the bronchus. So artery is done, that's the highest thing. And then you have the bronchus, that's the middle thing. And then you have two pulmonary veins. Okay, these two are pulmonary veins. Okay, remember this, ABV for the left lung. Now, the right lung. The right lung, as I told you guys, it has 3 lobes and 2 fissures. All right. So this right here, which is kind of more horizontal, it's going to be a horizontal fissure. Look at this. It separates the upper lobe and the middle lobe. Middle lobe is the smallest one, the small one. All right. And then you have your oblique fissure, which separates the middle one and the lower lobe. All right. Again, you have the hilum, same thing. And here the root is BAV instead of ABV, because here you have your bronchus coming first. You can see this, bronchus is the highest. And then you have your artery. Okay, your pulmonary artery is the second thing, it's just below it. There's the bronchus, just below is the artery, just below is the vein. So you have 2 pulmonary veins on both sides. Again, remember this. ABV for left, BAV for right. All right. And you have to also remember 2 things on the mediastinal surface, which are clinically important. You have your superior vena cava, this thing, and the azygos vein. So on the right lung, you're going to have the superior vena cava, and from it coming the azygos vein. All right. Is it clear so far? All right. So now you're going to talk about the bronchopulmonary segments. Okay. I told you guys there is a lung, the whole thing. And now the left lung has 2 lobes, the right lung has 3 lobes, all right? Now these lobes are also divided. So you have lungs, you divide the lung into 3 lobes, and then these 3 lobes divide into 10 on the right side. And on the left side, the 2 lobes divide into 9 bronchopulmonary segments, all right? So lung lobes, and then bronchopulmonary segments. Again, you just follow the order. The primary bronchus enters the lung. From the primary bronchus, you have secondary divisions. Each of the secondary division enters its respective lung lobe. All right. Now, from the secondary bronchi, you have further divisions to something called tertiary bronchi. Now, one tertiary bronchi supplies one bronchopulmonary segment. You can see this image, right? And this whole thing right here, that's the lung. All right. This is one lobe from the right lung. This is the superior lobe of the right lung. And even on the superior lobe, you're going to see this is a bronchopulmonary segment. This is a bronchopulmonary segment. This one, bronchopulmonary segment. All right. Now, you have something called connective tissue septae, because what happens is, how should I say? All right. The lobes are separated by fissures. You have your horizontal fissure, your oblique fissure. All right. Now, the bronchopulmonary segments are separated by connective tissue septae. That's all you need to do. And you also know that to have like a venous drainage of these parts, you're going to have the blood vessels running inside these septae. Septae are basically like divisions, just walls, okay? Like really thin walls made up of connective tissue. So these are really thin and they separate the bronchopulmonary segments. Like the fissures are properly visible. The connective tissue septae, they are not easily visible. Like they're visible on the microscope, but to the naked eye, they're not easily visible. Now, also you have your diseased segments. So let's say you have injury to one segment. Let's say this segment, all right? A good thing here, you have to know it clinically, is that if this part is injured or this part is infected, anything of that sort, you don't have to cut the entire lung off. You can just cut this part and everything else will function normally, all right? Again, the right lung, all right, 10 segments. 3 lobes, 10 segments. So 3 in the superior lobe. There's the superior lobe, you have 3 segments. The middle lobe has 2 bronchopulmonary segments, and the inferior lobe has 5 bronchopulmonary segments. Now, on the left lung, you have 9 segments. So you have 4 in the superior lobe. You have these two in the superior lobe. And then in the inferior lobe, you're going to have 5. Now, each of these segments has a name. This one's apical, this one's anterior, posterior. But when it comes to questions, it's a choice for you guys to remember these names, but you can solve them without remembering 19 names, because 10 here, 9 here, it's going to be 19 names. You don't have to remember all of those. When I'll do the practice questions at the end, I'll show you guys, all right? But again, it's an option. If you guys want to remember it, it's completely on you. But you can solve it without remembering 19 names. And I'll show you guys later on, all right? Again, remember, right lung, 3 lobes, 10 segments. Left lung, 2 lobes, 9 segments. Please remember this. Now you have your blood supply and lymph drainage. Arterial supply, it's going to be your bronchial arteries, which come from the thoracic aorta. Venous drainage, you're going to have the bronchial veins, which drain into the azygous system. On the right side, you remember the azygous vein. All of this is going to go there. And then for the lymph nodes, remember these ones. I'm not sure about these two, but lymph node, you have to remember. Bronchomediastinal lymph nodes. All right. Again, bronchomediastinal lymph nodes. Easy. Just by the name of it, it drains the lungs and parts of the heart, mediastinal. All right. Now, there is this important point to note, and I was actually confused about this up until second year. So a whole year of confusion. There is a difference between bronchial and pulmonary vessels. The vessels which enter through the hilum, they don't supply the lung tissue. No. These are meant for oxygen exchange, all right? These are purely meant for oxygen exchange. The ones which supply the lung tissue and make sure that the lung tissue is alive, these branches directly come out from the aorta, all right? These are the bronchial arteries. The bronchial arteries, the bronchial veins, these are supply and drainage of the lung tissue. Pulmonary arteries and veins are for oxygen exchange, oxygen, carbon dioxide exchange, okay? That's the main difference, remember. Now, let's talk about some clinical applications or pathologies. It just means like what can go wrong in the lungs. So for you guys, it's 2 things. You have bronchogenic carcinoma and you have pneumonia, all right? Bronchogenic carcinoma, I told you guys something. When you check in the carina, if the carina has changed shape or it's looking weird or something, it's probably going to be bronchogenic carcinoma. Just by the name of it. Broncho, the bronchi. Genic, starting from the bronchus. Okay, so bronchogenic carcinoma comes from the bronchial mucosa. Now, main symptoms. The main symptoms you're going to have is cough, hemoptysis. Hemoptysis means you cough up blood. All right. When you cough, blood comes out. So cough and hemoptysis, and then you're going to have something called Horner syndrome. I'll tell you guys on the next slide. And it can spread through the lymph, it can spread through blood, and it can spread basically anywhere in the body, but mainly it's brain, bones, and suprarenal glands. I don't think they really ask about this, where it spreads. I don't think they ask about this, but it's good to know. This is the most important thing in the lecture. If you guys don't remember anything, remember this, okay? If the tumor, if the bronchogenic carcinoma, if it's at the apex of the lung, instead of being here at the center, let's say it started here, all right? It's gonna form something called a Pancoast tumor. Remember this, okay? One question every year has come from this. Now, there are different things which the Pancoast tumor can lead to, and the first thing is thoracic outlet syndrome. Yep, thoracic outlet syndrome. So basically what happens, you can see this, all right? You have something called the brachial plexus. You guys will take it in MSK. Basically, brachial plexus is this spider web network of nerves which supply sensation and motor control in your arms, both of your arms. There is a brachial plexus here, brachial plexus here, and it basically controls your arms. All right. The thing is, the brachial plexus passes through a really narrow spot because in this region you have a lot of structures, like a gazillion structures are sitting right here, and they're really close to each other. So if anything goes wrong, one thing is compressing the other, and you now have problems. All right. You can look at this diagram here. The brachial plexus is kind of going under the clavicle. You have your clavicle here, and you have the first strip. The clavicle, the first strip, and then the shoulder joint. Clavicle, the first strip, and the shoulder joint. This space is really small, so it's kind of going in this direction. All right. So already the space is really tight, and if a tumor comes in, it's completely gonna compress there. All right. Now, if it compresses there, obviously you're going to lose blood supply, you're going to lose nerve supply. So you're going to have pain on the medial side, this side, okay? This side of the arm, you're going to have pain, and there's going to be atrophy of intrinsic hand muscles, which means you have these muscles right here, but you also have muscles in your hands. This is a muscle right here, this is a muscle right here. Muscles also control your fingers. What happens is these muscles, they kind of fade away. All right, they become weaker. Atrophy basically means muscle loss. So these muscles are lost. So that's TOS. And now this is like Pancoast tumor, they will ask you. And even from Pancoast tumor, the most important thing they'll ask you is Horner syndrome. And the thing is, you will keep encountering Horner syndrome in first year, in second year, in third year. It's going to stay with you for long. So remember this, okay? Basically, what happens is the tumor grows here, and if it grows up and behind, you're going to have the sympathetic chain behind, okay? Now, where is it? It's going to be explained in the last lecture by my colleague Lotus, but you're going to have the sympathetic chain, and if that compresses, you're going to have three symptoms. Remember these. You're going to have to remember this forever, okay? Ptosis means your eyelid kind of droops. I'll just show you guys here, okay? Look at this. This guy's eyes are completely open, okay? Look at this is the affected side because the Pancoast tumor was, let's say, on this side, all right? So on this side, you're gonna have ptosis, which means your eyelid is gonna droop a bit, okay? It's not, your eyes will never be fully open. Now, meiosis is pupil constriction. You can see this guy's pupils. This guy's pupils here, like the eyeball. You can see the eyeball there, right? It's pretty big because it's dilated. Now, in meiosis, that's going to constrict. And then you have hemi and hydrosis. I'll break it down. Hemi means half, okay? So the tumor is going to be on one side. So this half is going to be affected. That's hemi. And hydrosis. And means absence, hydrosis, sweat. So absence of sweat on half side. That's hemi and hydrosis. Remember this. These two are the main, most important complications of Pancoast tumor. You have four more, but I doubt they're gonna focus on these. Focus on the first two. Those are the most important ones. The next one is superior vena cava syndrome. So basically, again, the tumor grows, it compresses on the superior vena cava. So it causes dilation of the head and neck veins because blood is not coming back. If there is a compression here, the blood which goes there by the arteries, when it comes back, when it's trying to go back to the heart, it's getting blocked. All right. So that's why these veins become engorged. And again, that leads to cyanosis. And dysphagia, you can see this. If the tumor grows here, it can compress the esophagus and you're not able to swallow food anymore. Okay. You're going to have hoarseness. Again, hoarseness, recurrent laryngeal nerve. I assume you guys already took this. Okay. If anything compresses the recurrent laryngeal nerve, hoarseness. You guys already know this. Okay. And now diaphragmatic paralysis. Lotus, she told that the phrenic nerve runs anterior to the hilum, right? So let's say on top, right here, if the tumor grows big enough so that it's now growing in front. It started at the top, now it's growing in the front. And if it grows in the front, it can compress the phrenic nerve, and that's going to cause diaphragmatic paralysis, okay? Now, I marked this important because multiple lectures discuss this, so I'm pretty sure you guys are going to get a question from this, okay? Now, the next pathology or the next problem is pneumonia. You guys probably heard of pneumonia a lot. What it is bacteria, viruses, fungi. There's an infection which causes an inflammation of the lung, and the symptoms are cough, chest pain, SOB is shortness of breath. Okay, shortness of breath and fever. Whenever you have an infection, you're gonna have fever for like 95% of the cases. All right. Now, with pneumonia, the important thing you have to remember is when you look at a chest X-ray, okay, most likely if I think they're gonna give you a question, they're gonna give it on a chest X-ray, okay. So when you see the chest X-ray, you can see this is the normal side. All the black area means there's air in there, which should be normal. When you see it this side, you can see there's something wrong here. It's white now. It's opaque, okay. So there is opacity here. That means there is pneumonia, all right. You can see this right here. So whenever you see a chest X-ray and you see an opacity, there's pneumonia right there. So we're done with the first lecture. Let's see what you guys remember. Yeah. Now this one is a tricky one. Let's see who gets it right. So a surgeon cuts the segmental bronchus, supplying the superior right lobe of the lung. So which bronchopulmonary segments are affected? All right. B. Correct. You guys are correct. Okay. Posterior anterior apical. Now, I told you guys about the trick, right? I'll tell you guys now. Listen, B is the correct answer. When they ask you any question of this sort, it's repeated. This has been repeated. Now, if they ask you anything like that, they're going to tell you, okay, superior right lobe of the lung. If you know that the superior right lobe has 3 parts, okay, if it has 3 bronchopulmonary segments, you just look at the options, look at the one which mentions 3 segments. Yeah, A mentions 2, C mentions like 5, D mentions 2, okay, B mentions 3. So superior right lobe of the lung, it has 3. This is 3. That makes sense. That's the answer. Okay. And it's most likely going to be such something easy like this. So the next one, patient comes in with chest pain. Scan reveals bronchogenic carcinoma growing anterior to the hilum of the lung. Which of the following is most likely compressed? Again, this one's repeated too. Pretty easy. Okay. Yeah. Phrenic nerve. You guys are right. Phrenic nerve is the answer. Okay. Now, this is a question about lobes. If there is a tumor above the horizontal fissure, which lobe will be affected? Read it properly. Horizontal fissure. See? Okay, you guys are right. Horizontal is only in right. Whenever you see horizontal, the left options are getting eliminated. They are out of here. Okay? And if it's saying above the horizontal fissure, it's going to be a superior lobe. C is the right answer. Okay? Now you have patient comes in with dilated veins of the head and neck along with cyanosis. A diagnosis of Pancoast tumor was made. Which of the following triad of symptoms will be likely present alongside the venous engorgement? This is a tricky question. Take your time and try to solve it. Okay. All right. B. Yeah, correct. Ptosis, meiosis, hemianhidrosis, classic Horner syndrome. They're going to ask this. Okay. Remember that. Now we're done with that. We learned about the lungs itself. Now there is stuff surrounding it. Okay. Now you guys might be thinking, okay, so you learned the lungs. Now there is stuff surrounding it. Oh, diaphragm and the ribs. No, you have the lungs, and then you have the diaphragm and all that stuff. Diaphragm, ribs is fine, but there is something between these two, and that's called the pleura. Pleura is basically like, how can I give you an analogy? All right, let's say you have a box of chocolates. Okay. The box of chocolates has 2 chocolates in it, okay? And these 2 chocolates are covered with a wrapper. The rib cage and the diaphragm, that's the box. The chocolate inside the wrapper is the lung itself. The wrapper is your pleura, okay? So before we actually study about the wrapper, what am I saying? The pleura, let's study about the surface anatomy of the lung, which means where can you locate important parts of the lung by just looking on the outside? Because you can't just go on and do an X-ray or an MRI for everything, all right? So just for the surface anatomy, when you look at the person, you should be able to figure out, okay, this part is here, okay? First thing, if you want to look at a person and you want to make an estimate of where the apex of the person's lung is going to be, the topmost point, this thing right here, You have the clavicle, you go 2.5 centimeters above, that's going to be the highest point. That's going to be the apex. Now you have the inferior border, okay? For the inferior border, remember these three numbers, 6, 8, 10. And these two are separate from each other by 2 points, okay? Like 6 plus 2 is 8, 8 plus 2 is 10. I'll tell you guys, okay? Now apex is a point, but the inferior border, a border is never a point. A border is like a line, all right? So this line basically connects 3 points. So you have point A, point B, point C. This line connects these 3 points. That's your border. So your point A, your first point, is going to be at the 6th rib mid-clavicular line. MCL means mid-clavicular line. So mid-clavicular. So you have your clavicle, you go at the center of it, you draw a line down up until the 6th rib. Okay, something around here. So this is point A. And then 8th rib at mid-axillary line, MAL, mid-axillary line. So from the armpit, center of the armpit, you can go down at the 8th rib, all right? And then 10th rib at the scapular line. So you go back at the scapula, and then you keep drawing a line up until the 10th rib, when you feel the 10th rib from behind, okay? So you have point A, point B, point C, connect them. That's going to be your inferior border, all right? Now, this diagram is important, and I'll tell you why. Important as in the chances of asking anything from this in the exam is going to be less, but for your knowledge, and it has clinical applications later on. So remember this, T2 and these two numbers, 4 and 6. I'll explain. This diagram talks about fissures, okay? So the oblique fissure is going to be in the same line. Okay, it's gonna be same curvature, same direction, same line in both the left lung and the right lung. Okay, some people might get confused, like, okay, the right lung has another fissure, so the oblique fissure is gonna be more tilted. No, it's gonna be the same thing on both the sides. Okay, and on both the sides, it's gonna be from T2 posteriorly. Yani you go back, you have your cervical spine, those are your C1 to C7, and then your thoracic spine from T1, T2. Okay, so from T2, you keep drawing a line up until your 6th rib. Okay, you have your 6th rib, and then the 6th rib connects to the sternum by a cartilage called the costal cartilage. So from T2 all the way to the 6th costal cartilage, that's your oblique fissure. Okay, look at this, from T2 all the way to the 6th costal cartilage. Okay, now this is present in both left and right lung, and in both of the cases, it's from T2 to the 6th costal cartilage. Okay. Now horizontal fissure only present in right. So this line right here, oblique fissure, somewhere in between, you draw a perpendicular line going up until the 4th costal cartilage. Okay. You draw a line from this already oblique line, you draw a line going towards the fourth costal cartilage. This is going to be a horizontal fissure. All right. So when you want to approximate the fissure, you look at the person, you locate their 4th rib, and then you imagine a straight line. Okay. Now these numbers are important, 4 and 6, because we want to listen for breath sounds, maybe in pro or anything like that. Yeah, you guys might want to isolate which lobe you guys are listening to, okay, with a stethoscope. So if you want to listen to the breath sounds of the superior lobe, okay, for the right rib, it's going to be above this one. So we discussed the fissures. The fissures start from the same point, but end at different points. The horizontal fissure ends at the 4th costal cartilage, and the oblique fissure ends a bit below at the 6th costal cartilage. All right. So you can just remember this diagram, just picture it in your head. So for the right side, this is the superior lobe. For the left side, this whole thing is the superior lobe. Okay. So above the 4th rib for the right side, above the 6th rib for the left side. Now, obviously, you're going to have middle lobe, which is right only, and you place it between 4th and 6th. Now, for the inferior lobes, you don't place it below 6th. Okay, you go back here. You can see this. You go back on the posterior chest wall, and that's where you place it to listen to breath sounds of the inferior lobe. Are you guys clear so far? Is everything clear so far? Okay. Now, let's move on. We talked about surface markers. Now we'll actually discuss about the chocolate wrapper. Okay, the pleura of the lung. Now, what it is a bilayer serous membrane covering the lung. So this is the lung right here. And then you have this bilayer membrane. Bilayer means it's two layers. You have your parietal pleura, which is more outside, and visceral pleura, which is the inner layer. All right. And it's a serous membrane, which means these two layers are going to produce a fluid to prevent friction. Okay. More on that later. But just know that it's a serous membrane, and the fluid it produces is more watery in consistency as opposed to mucus. If it's a mucous membrane, the fluid the membrane secretes is going to be more thick. All right. This one is more liquidy. Now, parietal pleura is the outer of the two layers, and it's basically covers everywhere. So it goes all the way from the cervical, the costal, the diaphragmatic, even the mediastinal, like a proper covering of the entire lung. But it doesn't stick to the lung because it's the outer layer. The one which actually sticks to the lung, hatta even goes inside the fissures, is a visceral pleura. Okay, it contacts the lung, is the inner of the two layers, and even extends inside the fissures. Got it? You guys got it? All right. So again, this is your parietal pleura, which is more outside. This is the, let's say, the ribs. This is your parietal pleura. This is the visceral. This one is the visceral pleura. This is the lung. You can see the labeling here. The lung, the visceral pleura, the parietal pleura, and the space between these two is the pleural space. Okay. Now, there is a serous fluid which fills this space. This space is not empty. There's fluid in there. Let's say if there was no fluid, what's going to happen is when the lung will expand, the visceral pleura will hit the parietal pleura and it will scrub on it. Okay, it's going to cause friction. That's going to cause pain. Not good. So the fluid kind of prevents the visceral pleura from touching and scrubbing on the parietal pleura, preventing damage and fibrosis. Okay. Now, costodiaphragmatic recess. So it's distance between the lower border of the lung and the lower border of the parietal pleura. Okay. The main thing you have to know about costodiaphragmatic recess, they won't ask you what's the distance between them. Okay. The main proper thing you have to know is that when you take a deep breath, okay, there is this residual space kind of at the bottom right here between the lowest part of the lung and the lowest part of the pleura. So the lung 6, 8, 10. Okay. Below that, you still have 11 and 12. 11th and 12th ribs. Okay. 6, 8, 10 is the inferior border of your lung. 11th and 12th ribs, that's an empty space. So whenever you take like a deep breath, the lung expands and fills that space. That space is the costodiaphragmatic recess. Typically, it's going to be empty. When you're breathing in normally, when you're not taking in deep breaths, that space is going to be empty. There's going to be nothing there. Okay. Now you have your borders of the pleural cavity itself. You can see this. This right here, it's a lung. This is the lung. You can see this. 6th, 8th, 10th. That's it. 6th, 8th, 10th. Now you still have 11th, you still have 12th. All of this extra gap, that is the costodiaphragmatic recess. And when the lung expands, this tiny thing will fill with air and it's going to completely fill the space. Okay. So the first thing, yeah, cervical pleura. The cervical, same thing, is the upper border. Okay. And this pleura can be punctured by something called subclavian venipuncture. So let's say you want to inject something through the subclavian vein. All right. Let's look at something around here. If you want to inject something in the subclavian vein, if the injection is not done properly, it can puncture the cervical pleura, and we don't want that. Okay. The next thing is the costodiaphragmatic recess is the lower border. Again, there's the upper border of the pleura. The lower border of the lung is 6, 8, 10. The lower border of the pleura is the costodiaphragmatic recess. So it's at the level of 12th, the 12th rib. Okay, is the widest point. It at its widest point is 2 rib interspaces wide. You can see this 10th, 11th, 12th, 2 rib interspaces wide. That's how wide it is. All right. Yeah, the last topic is going to be innervation of viscera. That's going to be covered by my colleague Lotus. Okay. Now let's talk about the nerve supply of the pleural cavity. It's not complicated. It's just this image. Okay, I don't remember them asking us about the nerve supply itself, but you have to know it. Okay, they might change up something. It's not something you completely ignore. Okay, but the main point you have to know, if you forget all of this mumbo jumbo right here, the main thing you have to know is that the parietal pleura has a somatic supply, which means if you, let's say, hypothetically, take a pen and just touch my parietal pleura, I'm gonna feel pain. Okay. And the visceral pleura, the inner one, has an autonomic supply, which means if you take a pen and try to touch it, you won't feel pain directly at that space. It's gonna have something called referred pain. Again, what that is, it's gonna like my colleague Lotus will explain what referred pain is. But just to summarize it, it basically means you won't feel pain at the point of damage. You're gonna feel it somewhere else. For example, let's say I take a pen, I poke it on my parietal pleura, I feel it right here. Okay. If I poke it on my visceral pleura, I'll probably feel it on my shoulder. Okay. On the skin of my shoulder. Why is that so? It's because of something called dermatomes. Okay. So once you press here, you might trigger one dermatome. The dermatome will have a pain somewhere else, not at the exact same point, but somewhere else. Okay. Now just to go quickly through this. Yeah, the pain of myocardial infarction. Exactly. The pain is in the heart. The problem is in the heart, but then you feel the pain in your jaw. Okay. Yeah, exactly. Now, just to know quickly, the parietal pleura has somatic nerves and you will feel pain directly in there. Okay. The costal and peripheral part of the diaphragmatic pleura. Okay. So this is diaphragm, this is the diaphragmatic pleura. Okay. So the diaphragmatic pleura on the outside parts is supplied by intercostal nerves, and the central part is supplied with the phrenic nerve. Okay, and the phrenic nerve is an autonomic nerve as far as I remember. Okay, the visceral pleura is again no sensory innervation. It's autonomic and it is derived from the anterior and posterior pulmonary plexuses. I'm not sure what the phrenic thing though. I'm not really sure about the phrenic thing. I think it's still somatic. Okay, but for a fact, I know that the visceral pleura, 100% is autonomic. It's going to have referred pain. Okay. Now, we'll talk about problems in the pleura itself. You're going to have two things. You have open pneumothorax and pleuritis. Okay. Before we go into what open pneumothorax is, you have to know what pneumothorax is. Again, just like Horner syndrome, pneumothorax is another bug that's going to be in your hair all the way through fifth year. Okay. And it's important to know what it essentially is. So you have your pleural space, your pleural cavity, whatever you like to call it. It should usually have fluid in it. But if air enters it, that's going to be a problem. Okay. Air entering this part, that is a pneumothorax. Now, an open pneumothorax is, let's say someone got stabbed. Okay. Someone got stabbed, their parietal pleura got punctured, and because of that, now you have air entering the space. Okay. Air enters in the pleural space because there is a stab wound, there is an open wound, and air is now entering it. Now, how does this work? Let's say, again, when you start inspiring, all right, the diaphragm contracts and the pressure in your chest, okay, the pressure in your thoracic region, the pressure drops. And as soon as the pressure drops, air from outside will come. You already know that, okay? Normally, if the pressure drops, you breathe in air and air should come from here and then enter the windpipes into the lungs. But again, if the pressure drops and you have a stab wound here, that's a puncture. So air will also come outside from outside through this hole inside the pleural space. Now what happens is air kind of pushes. Air is kind of coming in here, it's kind of creating a pressure by its own and it's pushing the lung on the other side. Okay, you can see this. This is the part, let's say the stab happened here, okay? And now you have air entering it. This lung collapses and the whole thing shifts on the other side. So on inspiration, the mediastinum, so you have your lung, heart, whatever. The mediastinum shifts on the unaffected side, okay? Now when you expire, the diaphragm relaxes, okay? It kind of comes back up. And because of that, the pressure increases in the chest cavity. And because the pressure increases, the air will go out from the same hole. The air will go out from the same hole and the lung kind of comes back a bit. But the mediastinum shifts to the affected side. Again, inspiration, the mediastinum shifting here because of pressure from air from the outside entering the hole. Okay. And on expiration, it comes back to normal. Okay. That's open pneumothorax. Did you guys get it? Did you guys get the whole inspiration, expiration thing? Did you guys understand it? All right. Now you have pleuritis. Pleuritis is again inflammation of the pleura itself. Okay. Inflammation of the pleura means the pleura kind of, it becomes inflamed, it becomes damaged, it becomes thickened, whatever. But the thing you have to remember in pleuritis is there's going to be a pleural friction rub. For example, in you have your pericardial thing, right? You have your pericardial cavity, right? Now, if something happens there, you're going to have your pericardial friction rub. Same thing here, you're going to have a pleural friction rub. Okay. Another thing is you check fluid level in X-ray. Now, you can look at this. If there's pleuritis, there's going to be excess serous fluid accumulating, and you can see it on X-ray. Okay. The difference between this and the pneumonia thing is pneumonia can be happening even here or here. Okay. This will always be down, and there's going to be a fluid level. Okay. You can see this is where most of the fluid is, and then some of the fluid is above, and then there's going to be like this clear line. In pneumonia, when you look at the X-ray, it's not going to be such a clear line. Okay, you can see it's clear. In pneumonia, it's going to be a hazy line. In pleuritis, it's going to be a clear line, like a proper demarcation. Okay. Now, obviously, when you have inflammation, you might also have pain, and pleuritis causes sharp pleuritic pain, which worsens on breathing. Why? Simple. If you breathe, the visceral and the parietal pleura get more close to each other, and this increases pressure, especially on the parietal pleura, and then you're gonna have pain. Okay. Again, it's the same thing. You have the costal pleura on this side. It's applied with the intercostal nerve, and then it's gonna have your local chest pain. Okay. Now, mediastinal pleura, phrenic nerve is affected. Oh yeah. The thing I had a doubt before. The phrenic nerve is affected, and then you have referred shoulder pain. I remembered this. Okay. Phrenic nerve is affected, you're gonna have referred shoulder pain. I think that's it. And do you guys have any questions about pleuritis? Anything which confuses you about pleuritis? No? All right. This is the last topic, thoracentesis. Okay. You can see this. Let's say the person got pleuritis. Okay. Now there's fluid in his pleural space. So what we do is we tell the patient to kind of lie in this way, just so that all the fluid can enter this back point, because from this point at your back, that's where a needle will be inserted, and from there the fluid will be taken out. Okay, that's essentially what thoracentesis is. Okay, it's a procedure where we insert a needle in the pleural cavity to drain out excess air in case of a pneumothorax, fluid in case of pleuritis, or blood in case of trauma. Okay, now where is the needle inserted? That's kind of important. Okay, for this, just remember basic fluid dynamics. Fluids, they kind of act with gravity, okay? So if you have fluid, if you have excess fluid in the pleural cavity, gravity is going to act on it and it's going to go down. It's always going to be down, okay? So what you do is seventh to ninth intercostal space. So you have your seventh rib, you have your ninth rib, and the intercostal space of any of these, okay? At the mid-axillary line. So just kind of here, okay? Mid-axillary line. And 1 to 2 intercostal spaces below the fluid level. Why? Because if we keep it at the fluid level, if we keep, let's say this is the fluid level, you want to take a needle and you want to pierce it here, okay? The rest of the fluid is still here. And this is going to be pointless. But if you go a bit below and pierce it, there's going to be drainage of fluid, okay? That's going to be for fluid. Now for air, air is going to be up. Fluid is going to be down. That's why you make the patient lie down so that the fluid comes down. Now air will float, okay? So now you're going to go into the second intercostal space at the mid-clavicular line, right here, somewhere around here, Okay. Now, needle is inserted in the upper border of the intercostal space to prevent damage. This is the same thing which my colleague Lotus discussed about, just to prevent damage to the intercostal nerves and stuff. It's the same thing. Okay. Now, I think that's about it. Do you guys have any questions so far before we jump into the questions? Any questions about? No, 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 good. Now, first question. Why did that go first? All right. 27-year-old man presents to the emergency room with a stab wound superior to the medial 1/3 of clavicle. Stab wound superior to the medial 1/3. Tension pneumothorax. What pleura is damaged? It's pretty simple. It's pretty easy, pretty simple. A, all right. A. Yeah. What did that come? Oh my, I think I messed up the order. Whatever. Okay, both of the answers were A. The patient is getting a thoracentesis. Where should the chest tube go through in the procedure? Okay, just know superior border of lower rib, just so that you don't affect the intercostal nerves and you actually are more close to the collateral nerves, because those are not that important. They are not as important as the intercostal nerves. Okay, so just know this superior border of lower rib. And I apologize, I kind of messed up the click order. Okay, just know this, you're gonna be fine. Now, there's the last question. 23-year-old man presents to the emergency room with a stab wound on his chest. He has difficulty breathing and veins in and out of consciousness. What could be the cause of his symptoms, respectively? Read this question. Read this. It's a bit tricky. Read it. There's a stab wound on his chest, and he has difficulty breathing. C. All right. Yeah, C is the answer. Again, you have a stab wound, it's going to be open pneumothorax, and the patient is going to bleed. So because of that, the blood is not reaching their brain because they just don't have enough blood. They're losing blood. And because of that, they're just going to go in and out of consciousness. Okay. And yeah, I think that's about it for my part. And my colleague will now take over. Right.
Okay, now we'll be going through our last lecture of this crash course. Thank you guys for sticking by so far. This lecture, صراحة, in all honesty, I have no idea why it's in CVP block, but and it's a bit more on the difficult side, especially if you've still not taken any blocks except for foundation. But inshallah, I'll try to make it as simple as possible. The points that I focused on are the ones that she's most likely going to ask you about, because the others are honestly just irrelevant when it comes to CVP. But we'll be there for the completion's sake. طيب, first of all, we're going to be talking about the nervous system. Now, the nervous system is going to be divided into two parts anatomically. So what does this mean? This means that the nervous system is divided based on the organs or the structures, not function. So it's divided into two organs, the brain and the spinal cord. This is going to be the central nervous system. Now, the second anatomical part is going to be the peripheral nervous system, and it's basically all the nerves that are coming out of the central nervous system. We have 12 cranial nerves, and you guys are, I'm pretty sure you guys covered them really well or well enough in FND. And they're going to be the nerves that control the motor and sensory innervation of the face. And for your spinal nerves, we have 31 pairs of spinal nerves, and they are going to have an associated ganglion. What's a ganglion? It's basically a collection of cell bodies in a capsule sort of form in the central nervous system. Now, why does it matter if we have cranial nerves or spinal nerves? It matters because our cranial nerves, as we said, are only going to be contained within the face. And for our spinal nerves, they have their associated ganglion. And another thing is that they form a meshwork of nerves, and this is what we call a plexus. As you guys will move further, actually in renal, you'll be encountering a plexus. It's going to be called as lumbar and sacral plexus. You'll also cover the brachial plexus in MSK, but basically all of these are just meshwork of nerves, and they're formed by the spinal nerves. Now, hope everything is clear so far. Now, when we're talking about function, we divide the peripheral nervous system. Again, what's the peripheral nervous system? It's the nervous system with the 31 pairs of spinal nerves. It's going to be divided based on its function into either somatic or autonomic. Now, soma means body. I don't know what language is it. Is it Greek or Latin? بس اللي هو إنه soma means body. Now, the somatic nervous system will have both sensory and motor fibers. These nerves are going to be controlling things that are voluntary. So it's going to contain voluntary actions. So let's say that I want to move my arm like this. This is going to be voluntary. How is it controlled? By the somatic motor fibers, okay? Now, when we're talking about, again, soma means body. When we're talking about sensory fibers, we mean skin. So right now, if I were to caress my hand, I'm feeling it. This is going to be my somatic sensory fibers. They're going to take sensation from my skin. Now, when we're talking about the autonomic nervous system, a good way to remember it is autonomic automatic, which means it's involuntary functions. It's functions that I don't have any control over. بالمنطق, or like by logic, when we're talking about automatic innervation, we're talking about innervation of the organs and glands, because obviously I cannot control right now how my heart is pumping by itself, يعني subhanallah, or how when I get nervous I start having my sweat glands secrete sweat. I don't have control over that. That's autonomic nervous system. And again, it's involuntary function. We have visceral motor, which means the motor movement of my viscera, which could be an example of that would be my heart pumping. Another example of that would be peristalsis, which is going to be the movement of my GI, or the way my GI and esophagus moves to expel or move food within it. And I have visceral sensory. Now, believe it or not, we feel sensations from our organs. We can feel pain from within it. Now, the difference between the somatic sensory and visceral sensory is that visceral sensory is a diffuse, weak type of pain. It's poorly localized. You can't really feel it over a one specific concentrated spot. Compared to somatic sensory fibers, where I feel it very much localized. يعني if I were right now to cut my finger, I'm feeling it from my skin. It's very localized. I can point directly to where I'm feeling the pain. But that's not the same story with visceral sensory. It's more vague. Now, the autonomic nervous system, which is automatic, again, it's not under our control, is further subdivided into sympathetic and parasympathetic. What does this mean? Again, you guys know probably, but sympathetic is going to be my flight or flight system. It's going to be activating. Hold on one second. Someone's talking. Okay, yeah. So I have my sympathetic division and my parasympathetic division. Now, sympathetic is going to be fight or flight, which means that it's controlling my body functions. Again, whenever you want to remember the functions of a sympathetic division or a sympathetic nervous system or the sympathetic division of the autonomic nervous system, I want you to think as if, how would I react right now if someone was chasing me down or a lion was about to eat me? What body functions would I have? That's what I want you to keep in mind. Now, for the parasympathetic division, this is going to be rest and digest. So think of it as you chilling right now. You're in parasympathetic right now, unless you're really stressed about the exam. Hold on. Were you guys listening to me when I was discussing the sympathetic and parasympathetic division? Or was it? Could you guys hear me or was I muted? Yeah, okay, there you go. Okay, thank you. Now for the cells of the nervous system. Now, one cell primarily will form most of your nervous system. Obviously, there's more cells. You don't need to know it at your level. But right now, what's the primary cell of the nervous system? You probably know. What is it? The primary cell of the nervous system. It's right there on the slide. No, not multipolar. Okay, neuron. We'll get to what multipolar neuron is. But neuron is the functional cell of my nervous system. Now we have parts of the neuron. First of all, we have our cell body, and here is going to be the axon. So the cell body, I want you to imagine maybe a rat, and the body of the rat is going to be the cell body, and the tail of the rat is going to be the axon. Make sense? So the cell body has dendrites. Dendrites are these big hairs that are found, or again, think of it like the body of the rat. The body of the rat is hairy. It has a lot of spikes. So think of it like it's the dendrites. And the dendrites are responsible for receiving information. So again, we said that the neuron makes up the nervous system. Do you have one neuron alone? No. You have multiple neurons making up the nervous system, which means I'm a neuron right now. There's a neuron beside me. How do we communicate? Is that whatever impulse or information it's received, it will send it through my hairs. It will receive the impulse through the dendrites, and the nucleus or the cell body will integrate that information. And then I want to decide what I want to do. So maybe I want to generate another action potential, and this is where it's going to be propagated along the axon. I'm pretty much sure you guys are kind of familiar with everything I've said due to FND. And again, you have the axon. The axon will transmit the information. The axon is wrapped with myelin. Myelin is just white matter, okay? And the cell body is going to make up the gray matter, okay? Everything clear so far? Hopefully it is, okay. Now, there's a classification. Again, we've said the neuron is going to be primarily what makes up my nervous system. But the thing is that nervous system has different functions. Again, we know that we have our sensory innervation, we have our motor innervation, we have our autonomic innervation. So not all of the neurons will have the same function, which is what gives us 3 types of neurons. The first, again, I want you to follow me here with the picture. The first that we have is going to be my pseudo-unipolar neuron. Now, first of all, what does pseudo mean? Like, this is just general information. Fake, exactly, fake. Unipolar, uni means one, polar means pole. Now, as you guys know from the anatomy of the neuron that we discussed, we have a neuron right there, the cell body, and an axon. So it has poles, it's a polar body. If I were to have one pole, this means that it will be unipolar. But here, I want you to follow with A. Here I have the cell body. I have here one pole, right? But then it will start dividing into 2 different directions, which means it looks like it's unipolar. It looks like it has one pole, but it's not actually unipolar. It splits into 2, right? So this means that it's pseudo-unipolar. It's fake unipolar. Sometimes people just call it straight up unipolar. Don't get confused. It's pseudo-unipolar. There's no unipolar neuron. Because دايما في the cell body, there's a tiny stalk right here, and then it splits into 2. Now, the function of the pseudo-unipolar neuron is going to be a sensory neuron. So whenever we feel something, we feel it using the pseudo-unipolar neuron, okay? This is very important. Now, the second thing is going to be a bipolar neuron. Bipolar, again, you can see here the body, and you have 2 poles, 1 body, bipolar neuron, very straight to the point. Again, 1 axon, 1 dendrite. Now, this is going to be the rarest type of neuron in the body. Why? Because it's also sensory, but it's sensory for special senses, which means I feel with it. Things like light, things like hearing, those, again, you guys will know later on, but those are known as special senses, and they're felt by the bipolar neuron. Bipolar neuron is not found a lot. It's only found maybe in my nose, in my eye, which is why it's going to be the more rare type. Bipolar because 2 poles, 1 cell body. Now, for the multipolar neuron, and this is, again, do you see why it's not multipolar neuron that makes up the nervous system in general? Is because the multipolar neuron has 1 axon and multiple dendrites, so it will receive through the hairs, integrate the information, and then send out through the axon the information. What does this tell you? If I'm receiving sensation or information through my dendrites and I want to send a command, what would the function of a multipolar neuron be? Would it be sensory? Would it be autonomic? Would it be what? Motor, exactly. It would be motor. You can remember it as multipolar M, motor. So again, it will receive the sensation and then integrate it and then send out a motor function. Again, this is important. So what's the sensory neuron? Sensory neuron, generally. Which of the three types? So the unipolar. طيب, what about motor? You guys already said it. Multipolar, exactly. See, perfect. Next. Now we're going to look through the images that Dr. Olena drew. صراحة, I know she drew them for the purposes of making it simpler, but to me, I really found difficulty because the lines are very thin. The picture is not really too clear. فإنشاءالله, I'll walk you through it. We'll understand everything that she's talking about. So again, this is simply a review. The nervous system is divided anatomically into central and peripheral. The peripheral nervous system is further divided into my, hold on. Yeah, the nervous system is divided into somatic and autonomic. Somatic, specifically the peripheral nervous system, is divided into somatic and autonomic. Somatic means what? Means what? Means body. What does it innervate? It's right there on the slide. Skin and skeletal muscle. So anything that I have voluntary control over or skin, it's related to the body, it's related to the word soma. This means that it's somatic innervation. طيب, automatic, it's going to be glands, smooth muscle, organs basically. Even your heart, it's going to be autonomic innervation, okay? طيب, next. Now we further divide, we said that the somatic is going to be what? Either somatomotor or somatosensory. Now another word that we could call motor is going to be efferent. And another word we could call sensory is going to be afferent. Why does it matter? I'll show you right now on the spinal cord cross-section and it would make sense. Now here we have our spinal cord cross-section. This is going to be central canal, don't worry about it. Orientation, anyways. We have here the anterior horn. This is going to be the posterior horn. And this is going to be the lateral horn. Question, can you see the lateral horn all throughout the spinal cord or only at specific levels? Okay, you jumped right into the answer, T1, L2. But yeah, it's not seen throughout the entire spinal cord. I only see it at specific levels, specifically from T1 to L2. That's the only part I'll see this tiny, like, wing right here. Otherwise, if I were to go, مثلا, let's say in my cervical spine, will I see my lateral horn? No, I won't. Again, ventral horn, dorsal horn, and lateral horn. Now, the thing about these horns is that they're gray matter. Gray matter is made up of, again, what is it made up of? Which part of the neuron? Cell bodies, exactly, cell bodies. Not dendrites. Dendrites are like integrated within the cell body. Not cell body, not dendrites. Don't confuse yourself. So cell bodies, here I'm going to find a bunch of cell bodies. Now, again, we said we have, yeah, both. Now we have, again, we said different types of neurons. Now, specifically here, the collection of cell bodies at the dorsal horn are going to be sensory, which means all of the cell bodies here are going to be ones for sensory neurons. When it comes to the ventral horn, it's going to be the collection of all the cell bodies for what? For motor neurons. What about the lateral horn? I said that the dorsal is sensory, ventral is motor, lateral what? There's one left. It's autonomic, but specifically what? Yeah, autonomic, sympathetic. Sympathetic supply is going to be at the lateral horn. I'm going to have the cell bodies there, okay? Hopefully that made sense. Yep, visceral, autonomic, sympathetic. Keep it at that. Then further on, I'm going to have my dorsal horn is going to, now I have the axons and I want to move the axons to go and form the rest of the nervous system. So now here I'm going to have the axons of the cell bodies converging and they're going to form the dorsal root. Now the thing about roots when you hear the word root, it means pure. It means it will either be sensory or motor. It can't be mixed. This is very important. Because again, بالمنطق, يعني I'm going from the dorsal horn, it only contains my sensory cell bodies, and then I'm going to go and take all of the axons, converge them to form a root. It will be purely sensory. Now, the thing about the sensory root or the dorsal root is that it's going to have a ganglion. What can you find in this ganglion is going to be, it's almost like a pouch almost, that contains the cell body of the pseudounipolar neuron. Recall how the pseudounipolar neuron is it has a little head and then a process, then it will split into two. This head, we're going to find it at the dorsal root ganglion. Make sense? Hopefully it does. Now for the ventral horn, again, same thing. What will I find in the ventral root? And again, I told you root, something very specific. Only motor, exactly. So I said ventral horn contains the cell bodies of the motor neurons. The ventral root will only contain motor neurons. طيب, together, now they're going to converge. The roots together are going to form one nerve. What is it going to be? It's going to be known as the spinal nerve. Now, what's important about the spinal nerve is that it's a mixed nerve. Obviously, I've merged the two pure roots together, the sensory and the motor, or the dorsal and the ventral, and I formed them into one, and this is going to form for me my spinal nerve. My spinal nerve is mixed. Now, we don't stop just right here at the spinal nerve. The spinal nerve will further divide. Why will it further divide? It will further divide into rami. Now, again, I don't know if it's Latin or Greek, but ramus means bridge. Obviously, as you guys know from roads, yani, you're usually at a certain road, and then someone wants to go into a different direction. Another person wants to go to the opposite direction. So obviously, the road will have two separate ways. It will bridge into two. This is the same concept that happens here, is that I'll have my spinal nerve, and then it's going to bridge into two. Why? It will bridge into the dorsal ramus and the ventral ramus. The dorsal ramus is going to be responsible for all the sensation and movement, because again, recall this is coming from the spinal nerve, it's mixed. It's going to be responsible for all of the sensation and the movement of my back. Now, ventral, obviously, what will it be? The anterior chest wall or the anterior body. It's going to be ventral and motor sensation of the anterior body, okay? Makes sense? Does the spinal cord cross-section make sense? Because this is only somatic, everything we've discussed so far. Any confusion? Can you guys hear me? Yes, okay. Everything was clear so far with the spinal cord cross-section? Hold on, why is it not sharing? Yes, alhamdulillah, okay. Let me share screen. Okay. Okay. طيب. Now we've explained the spinal cord cross-section. Let's go back to her image. So now we have the motor. And again, motor, what did I say? I said that it's going to be at which horn? Which horn is it found? Hold on, let me get the chat. Okay. Yeah, the motor. Where will I find the motor, like, part of the spinal cord? Where? Ventral or dorsal? Ventral, exactly. Now, ventral, it's going to, again, motor, when I'm talking about motor innervation, I'm giving out a command, right? Because I want to tell something to move, especially motor command, yani especially if I'm talking about the somatic nervous system. So I want to tell my arm to move or lift up. So this means that I'm going to be giving a function, which means I'm going to be exiting out, which means it's going to be efferent. So it's going to be leaving through the root right here. and it's going to be an efferent nerve, okay? So remember, efferent means exit, and I'm talking about the skeletal innervation, okay? Which means somatic, which means voluntary. Make sense? I hope this is not too confusing for you guys. Okay, hopefully it makes sense. Now we'll move on to the sensory. Now, sensory, it's going to be afferent. So for sensory, I'm receiving information. I want to tell my body what I felt. Maybe I just touched something really hot. So all the information wants to come to me. So I want to give it to my brain. So it's going to be afferent. It's coming to me, okay? So this is going to be sensory innervation. And again, we're talking about somatic, which means from the skin. I'm feeling something. Now, and again, what's important is that I will have a dorsal root ganglion. What can I find in the dorsal root ganglion? No, sensor, but specifically in the dorsal root ganglion. Specific, yep, exactly. The cell body of the pseudounipolar neuron, okay? This is important for some reason. She really stressed upon it. Okay. فخلص, just to go over her diagram a bit, is we're going to have here the ventral, it's going to be efferent, general, somato, because again, it's going to be for the skeletal muscles, so somatic, soma, has to do with the body. Efferent, because efferent, away or exiting, exit, it's going to exit, and again, it's going to go for the spinal nerve, and then it's going to supply, it's going to be found in what? The motor nerves are going to be found in both rami and in the sensory nerve. Will it be found in the dorsal root? No, exactly. Keep it clear. Root is pure. And it's going to go supply the muscles. Now, for the dorsal side or the dorsal horn, I'm going to have the cell bodies that are sensory. I'm going to have my pseudounipolar neuron taking or receiving the information technically. And then I'm going to have my ganglion, which contains the cell body of the pseudounipolar neuron. And again, found in both the spinal nerve and both rami, because I need sensation from both the anterior and posterior side. Inshallah makes sense. Now, for the autonomic nervous system, which is honestly, I felt like the more important part of the lecture, because again, it has to do a lot with your block. Somatic is not really that relevant. Yeah. So sensory cell bodies are in both. Yeah, the way. Okay, this is confusing. This is why I said, this lecture feels confusing for you guys. The nervous system is made up of a bunch of cells. It's not very strictly, okay, بس axon, بس cell body. يعني you have it in all over the body. Obviously, in more concentrations, you're gonna have a lot more cell bodies in the horn than axons. But again, you have here cell bodies, and يعني other neurons that are coming off from the root are going to be synapsing and going. Yeah, you have sensory cell bodies in the horn and in the dorsal root ganglion. But specifically, the cell body of the pseudounipolar neuron. Make sense? Don't confuse yourself, but know that the horns are made of cell bodies. The dorsal is going to be sensory. And in the dorsal root ganglion, I'm going to have the cell body of the pseudounipolar neuron, which is a sensory neuron. Don't go into details. طيب, for the autonomic nervous system, I have my sympathetic and parasympathetic. Sympathetic, which is fight or flight. Parasympathetic, rest and digest. Now, the general pathway for it is I'm going to have a nerve from the central nervous system. And again, this will make more sense when we actually give an example by the cardiac innervation. And it's going to go all the way and synapse with a ganglion. So again, it's going from the central nervous system, either my brain or my spinal cord. It's going to travel all the way and synapse with a ganglion, okay? That's the first neuron. The second neuron is going to be what? Post-ganglionic, because I've already synapsed with the ganglion. The nerve after is going to be post-ganglionic. Now, the post-ganglionic nerve is going to travel all the way and innervate my viscera, or my gland, or my smooth muscle, or my organ. Make sense? This is the general pathway for autonomic nervous system innervation. So I have the first nerve is coming from the central nervous system, either my brain or my spinal cord. It's going to be known as my preganglionic neuron. It's going to go presynaptic, my bad. Presynaptic, it's going to go and synapse with the ganglion, and it's going to make my postsynaptic or postganglionic, because the synapse, or basically the meeting, happens at the ganglion, postsynaptic or postganglionic neuron, which is going to go and travel to my organ to innervate it. Okay? We're going to move on. Okay. Now for the sympathetic nervous system, we'll go into more details. Now, first of all, what's the activities generally of the sympathetic nervous system? We're not just talking about the heart. So I want you, again, in this state, sympathetic nervous system, specifically, it's going to be from the autonomic, and it's going to be fight or flight. So diamond, keep in mind, someone is chasing you down, or you're in a really like dangerous situation. So what will happen to your heart rate, first of all? Like now you're really scared, you're really worried, you're really stressed out. Okay, let's say that you said your heart is pumping really fast. So your heart speeds up because you're really scared, you're really worried, because your body now wants you to run, wants you to fight. It will pump the heart more to increase the oxygen supply to my organs. Now, when it comes to blood pressure, have you noticed when you get really scared is what happens to your fingers? They turn really cold. It's not like when you're resting, your hands suddenly feel really cold. And that's because your vessels will constrict, and this will raise your blood pressure. Because again, you guys know from your cardiology, physiology, is that when the vessels constrict, I'm increasing my blood pressure. So again, we'll constrict the vessels, and this will increase the blood pressure. The blood supply itself, Kaman, will have priority. So I won't start supplying all parts of my body the same. Now I have organs that have priority for blood supply. So I want to deliver more blood to my brain, to my heart, and to my skeletal muscle. Why? Because skeletal muscle, I need to run. So now I need more blood supply to it. For the brain, I need to think. For the heart, I needed to increase the supply or oxygen demand of the body. So this will happen, the redistribution. And again, I'm going to remove blood supply from other organs. For example, in case you're right now really scared, do you want to go to the bathroom or eat? The answer will be no, you don't, obviously. So it will stop the peristalsis. Again, as I told you, is going to be the movement of the GI tract. So again, I don't want to digest anything right now. And I'm going to close the sphincters, which means I don't want to go to the bathroom, okay? Make sense? That's all it does. Pretty simple enough so far. Now, for the sympathetic nervous system, I want to go to the pathway of the heart and then explain it on the diagram just so that we don't lose track. So for the sympathetic pathway of the heart is, again, you have, what was it? We said that you're going to have a nerve for the autonomic nervous system. The general plan, how I want to innervate, is going to be from the central nervous system. I'm going to start. So the neurons are going to be located at the IML, intermediate lateral horn. This is going to be it, okay? This is the one, the lateral horn, that we said is only found from T1 to L2, okay? So we're going to have the neurons here, again, because it's at the central nervous system. And then we're going to have these specific neurons for the heart, because, again, wait, let me show you the picture. Okay, yeah. Because at the heart, at this like T1 to L2, not all of it is supplying best the heart. It's supplying other organs because again, it's visceral innervation. But specifically, best if I want to innervate the heart and the thorax, I'm looking at T1 to T4. Other levels will innervate either my stomach, my GI, whatever it may be. You don't need to worry about these. All I want you to know is that T1 to T4 is going to be thoracic splanchnic nerves that are going to be innervating specifically the chest wall, the heart, the autonomic innervation of the heart, okay? Now, I've had these neurons that are going to be at the IML, and they're going to be from levels T1 to T4. Those are going to be all preganglionic fibers. They're going to, again, take and form nerves that are going to go and exit the spinal cord, but specifically, where are they exiting from? They're going to be exiting from the ventral horn, okay? They're going to go alongside the motor somatic. So they're going to go exit from there. and they're going to go to the sympathetic trunk. Again, if you guys remember the chain, sympathetic chain, I think Rafa has mentioned it in her PAL briefly. The sympathetic chain, they're going to go there. And that's where they have their ganglions. Now they're going to synapse with the ganglions there at the sympathetic chain or the paravertebral chain. Why is it called paravertebral? Because right beside the vertebra. So at the paravertebral chain or the sympathetic chain, that's where they're going to synapse. And then after I synapsed, now I'm going to give my postsynaptic fibers. The postsynaptic fibers, a very specific name for them is going to be what? Is going to be, hold on, the cardiac splanchnic nerves. To break the name down, we have cardiac because they're going to be specifically post-sympathetic. This is very important. She stressed on it. They're going to be postsynaptic. My bad if I missaid. Postsynaptic or postganglionic fibers innervating the heart. Splanchnic means organ, which is why you're going to see that all of these organs that are going to be innervating other viscera are going to have splanchnic in the name. Okay, so cardiac, splanchnic. They're going to be post-sympathetic fibers. Again, so that I don't lose you, let's follow it on the diagram now. So first of all, where do I start off? What's the first location? Yani, where will I have the neurons? No, you don't. Lesser lumbar, greater. Don't worry about those. All you need to know is the cardiac splanchnic. And honestly, if they do ask, then that's insane. But I watched the recording and she didn't really pay much mind to them, so I don't think so. You'll cover your NGI and renal, all of that. So again, where will I find the cell bodies of the IML? Or wait, no. Where will I find the cell bodies of the autonomic nervous system, specifically sympathetic? Lateral horn. Another name, or the nucleus here, nucleus is going to be collection of cell bodies, is going to be the intermedial lateral horn, okay? Right here is going to be the cell bodies. Now I'm going to go and again, follow this purple line. I'm going to go right here, and where do I exit from? I exit from the ventral root. I will go the same pathway, or I'll have beside me, I'm a sympathetic nerve, presynaptic. I'm going to travel in the ventral root. Beside me is going to be the somatic motor, okay? Now I'm traveling, and I'm going to go all the way to the spinal nerve. And then I'm going to stop midway through the spinal nerve, and I'm going to exit out because I want to go to my sympathetic chain ganglion, right? The sympathetic chain, which is made of ganglions, a bunch of ganglions, paravertebral. How will I get to them is I'll leave through the structure known as the white rami communicants. So I'll leave through that structure, okay? And it's going to be from its name, what is it made of? It's made of white matter. When I want to leave through the white communicants, I'm going to be exiting. Now I'm going to go, and this is going to travel to the sympathetic chain where I have the ganglions. These ganglions, I'm going to synapse with them. The presynaptic is going to synapse with them. And then after, I want to go and innervate. I have the postsynaptic, the postsynaptic nerve. This is the second nerve. After I've synapsed in the ganglion, in the sympathetic chain, I want to go and innervate now my heart, okay? Make sense? Is this pathway clear? Okay. Now, one thing that I want you to guys look at is because the sympathetic chain is not just, again, we said that we are innervating not just the heart. I still have the other organs like my GI, for example, my gastro tract. I want to innervate that too because it's the same innervation. It's autonomic, it's visceral. So I could, some of the fibers, again, I want you to focus here. So we've went, and again, we're presynaptic. We've left through the white communicants, and we're in the ganglion right now. Some of the fibers or some of the nerves, after they've synapsed, they're going to go back inside into the spinal nerve. How will they go back? Is by the gray rami communicants, okay? So if I want to leave the spinal nerve, it's going to be by the white rami. If I want to come back, it's going to be by the gray rami communicants, okay? And then I can go and you guys see it, it's traveling in the spinal nerve and it's going to go innervate either the vessels of my GI, blood vessels, glands, whatever it may be, okay? Inshallah, it makes sense. So again, just to reiterate one last time, we're going to go through the slides and put it into words. So again, the origin, which is going to be at the, what? We'll get to it. We'll get to the blue. Anyways, so we have, first of all, the sympathetic pathway to the heart. So again, the neurons are going to be originating at the lateral horn, specifically for the cardiac fibers. They're going to be at the level of T1 to T4, out of the T1, L2, okay? So T1, T4 is going to be specific for the heart. At that level, I'm going to have the cell bodies for the heart, okay? Then I'm going to have the pre-ganglionic fibers or the presynaptic fibers, and they're going to exit the spinal cord by the ventral route. So they're going to run with the efferent somatic fibers. They're going to go all the way and leave by the white rami communicants, and then they're going to go and synapse. Now, the synapse will happen at the sympathetic chain ganglions, and then it's going to go and travel all the way and form postganglionic fibers. Those postganglionic fibers are going to be sympathetic, and they're going to terminate means stop or end, on the SA node, the AV node, and the cardiac muscle and the coronary arteries. Now, for the SA node and the AV node, what will it do? Again, you're scared right now, and this is going to be the innervation for that. What will happen to my heart? We've discussed it. Increase heart rate. So it's going to stimulate the SA node to increase the speed of conduction and cause the heart to contract really quickly. For the cardiac muscle fibers, it's going to increase contractility. What does this mean? Is increase the strength of contraction. So not only am I contracting faster, I'm increasing the strength that I'm contracting with to cause the heart to like splotch more blood. For the coronary arteries, again, this is important, is for the rest of my body, my blood vessels will constrict. But for the coronary arteries, which are going to be the arteries on the heart itself, they're going to dilate. Why? Is because my heart is increasing its function, it's increasing the movement it has, which means I need more oxygen supply, more demand to the cardiac muscle. Recall how I told you that we have priority of blood supply. The blood supply will get redistributed, and one of the places we will redistribute is the heart itself. We want to increase its blood supply by dilating the coronary arteries, okay? Now, for the activation, again, we've discussed all of this. Increase heart rate, force of contraction, and dilation of the coronary arteries. Okay. They are also for sweat glands, right? Yes, they are for sweat glands. Sweat glands will go, but they're going to go through the rami. So they're going to go, again, recall how I told you some of them will synapse and go back through the gray rami communicants, and then they're going to go through the dorsal and ventral rami. Yes, you want to innervate the sweat glands. Okay. Now, I've told you about the cardiac splanchnic nerves and that they're post-synaptic. The post-synaptic fibers, what do we call them? They're the cardiac splanchnic nerves, okay? طيب. A point about referred pain, just really quickly. Actually, this should be discussed. Okay, let's discuss it right now. So the thing about it is, let's go back to spinal cord cross-section, is I feel, again, I told you guys that there's sensation from these viscera. We feel from viscera. Again, it's not the same as the somatic pain where it's very localized and sharp. It's more dull and diffuse. But again, we do feel from our organs. So follow this light blue line here, okay? So we're going to go, this is, let's say it's the heart from 13, and we're going to go back retrograde. So the entire pathway that we gave supply to the heart, let's say something hurt my heart now, I'm going to feel and go back through a different fiber, obviously sensory. Sensory, again, sensory, it's going to be, what's the neuron that I'm going to be feeling with? No, the neuron that I'm feeling, pseudo-unipolar, yes, pseudo-unipolar. So I'm going to be feeling from my heart pseudo-unipolar. The pseudo-unipolar is sensory for both my somatic nervous system and my visceral. Be careful. So it's going to go back through the same pathway. So here, it's going to go back through the white rami communicants all the way to where? To the dorsal horn, okay? Now, there's a problem here, is you guys know, or you've heard probably, is that, let's say I were to have a heart attack, one of the ways that the patient will present, or the pain that they'll present with, is going to be not just pain to the chest or the pain to the heart, it's going to be pain that radiates to the left arm. Why? This is going to be the concept of referred pain, and it will come back with you each and every block because it's important when it comes to organ pain. So my organ is having pain. I'm going to have, again, as I told you, the light blue fiber, recall, it's going to go retrograde all the way back to the spinal cord to be sensed by the dorsal horn. But recall that the dorsal horn is also receiving nerves from other parts of the body, specifically somatic parts of the body. يعني skin or muscle, it's receiving the pain from there too. The thing is, let's say that right now I'm going back retrograde all the way to the spinal cord after I felt the pain in my heart. Along the way, though, I have nerves hitchhiking or having the same pathway going also to the dorsal horn. The brain, let's say, an easy way, or let's just say that it gets confused between what part is having pain, so it will feel pain in both. Does this make sense? It's kind of a goofy concept. No, not sure. Okay, they're going to go through the same nerve pathway. They're going to be innervated by different nerves, but both nerves will be interpreted, or the pain will be felt or told to the brain, I'm feeling pain, by the same area, the dorsal horn. The body will sense pain in both. I hope this made sense. So again, let's read the slide. So visceral sensory fibers will travel along the same nerves as the somatic sensory fibers. So I'm innervating my arm, I'm innervating the muscles there, I'm innervating the skin. But as they're both going through the nerve pathways and they want to go back to the dorsal horn, I'm going to feel, I can't distinguish anymore. The spinal cord won't always distinguish. And this is not always the case, by the way. Yani you can have pain only at the chest. It doesn't always have to radiate. But sometimes the spinal cord can differentiate, okay? All you need to know is that the somatic and the visceral, as it's going through its pathway, the somatic fibers will hitchhike on the same pathway, and it's going to be indistinguishable at the dorsal root. So these somatic nerves join the splanchnic nerve, or do they terminate at the same place? I don't really get you. They won't join they will go to the same, ultimately the same like integration system, or where the brain will be told that I'm feeling pain. It's going to be the same nerves, يعني more the same nerves, يعني the same integration place. كيف يعني terminate at the same place? No, they have different, like they're felt, okay, different nerves. This is going to be a nerve to my heart, but this is going to be a nerve to my somatic nerve. So nerve that's felt for the muscles and the skin. As they're going through, again, this one is going back and it's going through the sympathetic chain to the ganglion, and it wants to go back to the dorsal horn. This one will go to its own pathway, and again, together, they're having some meeting points within the spinal cord, and again, they're gonna go get integrated at the dorsal root horn, at the dorsal horn. This is the sensory integration center, right? So the body sometimes can differentiate between what part is having pain, فأل feel pain in both. Does this make sense? Don't overthink it. Just know that sometimes you can have referred pain, and it's because the fibers of the somatic will hitchhike on the visceral. Okay? I know it's a bit of a confusing concept. صراحة, I didn't quite get it till I was in second year doing my neuroblock. Yani that's how. Anyways. Question. يلا. يلا answer. Okay. No, there's no anatomy of the nose and the larynx. But صراحة, you don't really need to study it. You guys had Dr. Hassan, right? Solve past. Solve past 100% or 90%, let's say. He's going to repeat the questions. وصراحة, a lot of the concepts or the things that he discusses in his lecture are very not not important for CVP. But just make sure to solve past. I believe our batch, the 16th batch, they've collected his questions from all the exams. It's a file. I'll send it to you guys later on your batch group. Most of you guys answered B, so yep, it is the answer. And this is just the pathway. Bear with me. We have one more concept and we're going to be done. And it's going to be the parasympathetic nervous system. How do we feel, or how is our heart innervated when we're chilling right now, when we're resting, okay? Again, let's go to the slides first, then we'll go back and explain it on the cross section. So, for the parasympathetic nervous system, we're going to have the cell bodies. Now, they're not going to be at the spinal cord. They're going to be in the brain. Specifically from what? From a specific nucleus. You guys will know this more later. It's very advanced. But in my medulla, which is going to be a part of the brain stem, a part of the brain, you don't need to know all that, but all you need to know is from the medulla, we're going to have a nucleus that's going to be known as the dorsal motor nucleus of vagus. That's going to be its name. Memorize it. I don't think she'll ask about it, but anyways, this is going to be the origin. This is where we're going to start. So at the medulla, which is going to be in the brain stem, which is a part of the brain, we're going to have a specific collection of cell bodies known as the what? Dorsal motor nucleus of vagus, okay? And it's in the medulla. Now, we're going to have these fibers, either motor or sensory, because the vagus is a mixed nerve. It's both motor and sensory. And then they're going to go all the way from the cranial nerve, because vagus is going to be cranial nerve number 10, if you guys remember. And it's going to go all the way and synapse what? Almost inside or close to the heart. So the thing about the parasympathetic nervous system is, compared to the sympathetic, is that the postganglionic fibers are short. They're not like the sympathetic, where I travel after synapsing in my sympathetic chain. No, they're going to terminate. So I'll have a really long preganglionic fiber. And then once I want to synapse, which is going to be, by the way, my vagus all the way going. And then when I want to synapse to innervate my heart for the parasympathetic function, it's going to be a ganglia that's in the heart or close to the heart, okay? Make sense? So again, we have the collection of cell bodies that's going to be in the medulla, in the brain stem. Just know that it's going to be the dorsal motor nucleus of vagus. And then it's going to give out fibers. That specific fiber is going to be the vagus nerve. It's a mixed motor and sensory nerve. It's going to travel all the way, and then it's going to go to a ganglion that's close or inside the heart, known as the terminal ganglion. Okay? Terminal, recall, end means end. So terminal ganglion, okay? Make sense? Inshallah it does, okay. Now, it's a very simple pathway compared to the pathway of the sympathetic nervous system. Now, what does the parasympathetic nervous system do? It is going to be a system that wants to conserve energy, wants to restore your energy. So what does this mean? For the heart rate, my body is not in stress. I don't need as much blood supply. So it's going to be a slower heart rate. Now, what about, I told you, I'm not going to be digesting or eating or doing any of that when it comes to the sympathetic nervous system. But when it's the parasympathetic nervous system, what happens now? I want to digest. I want to secrete from my glands. When we mean here glandular activity, don't get confused and think sweat glands. No. This means glands that are مثلا in the stomach or in the respiratory system. They secrete juices to help the movement and to help digest the food, basically. And open sphincters. Now you can go to the bathroom. يعني your sphincters aren't, your body isn't telling your sphincters مو وقته. Okay? طيب. Where will they terminate? Again, I told you the terminal ganglion is going to be either close or within the heart itself or the organ. But we're specifically talking about the heart right now. Now they'll terminate again on the SA, AV node, and the coronary arteries. And everything will be opposite of the sympathetic nervous system. So it will decrease the heart, which means negative chronotropy, if you guys remember from physiology. It will decrease the force of contraction. So the contractility or the strength that the heart is contracting in, it's not a very strong push anymore. It's more timid. So a negative inotropy. And then we're going to have the coronary arteries. Again, recall, how did I say? We're going to have priority blood supply when we're in a stressful situation, sympathetic nervous system. Right now, we don't need it. We just give the heart its normal blood supply, which means slight constriction of the coronary arteries. We don't need to dilate them. And you can dilate blood vessels into many other parts of your body. So now I dilate the blood vessels to my GI because I need to digest, okay? Hopefully that made sense. Okay, this is going to be a table comparing the sympathetic and parasympathetic nerve fibers together. Don't worry about beta 2 receptors, unless you took it in physiology, then mali dakhal. Yeah, we pretty much explained everything. Now, just please remember that the IML, or intermediate lateral nucleus, that's found in the lateral horn, is going to be at the levels of T1 to L2, but specifically for the heart, it's going to be from T1 to T4. That segment of the lateral horn is going to be T1 to T4 is going to be responsible for the heart and thoracic cavity, okay? Okay. And again, as I told you, that the sympathetic is going to be longer, the post-ganglionic, because it will have to synapse with the chain that's at the vertebra and then travel all the way to an organ. Whereas the parasympathetic nervous system, it's one long nerve from the cranial nerve, specifically in the case of the heart, the vagus. It's going to go all the way, and recall, where was the vagus? It was hugging the esophagus. It's going to travel all the way. It's going to give its fibers to the heart in the thoracic cavity and synapse with the terminal ganglion that's either close or inside the heart. And then it's going to continue its pathway and go through the esophageal hiatus. What was the level of the esophageal hiatus again? Okay, exactly. Alhamdulillah. What runs with the... لا خلاص, we said the vagus. Esophagus, yeah. Esophageal hiatus, C10. And then it's going to go into my abdomen, and it's going to innervate other organs, not just the heart. So this is why the parasympathetic nervous fibers are short, because they're terminal. They're within or close to the organ. And that's it, pretty much, I think. This is going to be her Dr. Olina's table. الصراحة it's a bit vague, so that's why I ChatGPT'd this one. And I think we are done. Any questions, guys? Nope. Okay. All good. Okay, so inshallah, this crash course, me and my colleague were pretty inclusive with it. In case you're on a time crunch, يعني, this was your only source of lung anatomy review, inshallah, it should be inclusive enough. Just please make sure to solve the QR code at the end of Dr. Olina's lectures, because it will give you a very good idea of how she asks questions. And for your question collection from books, if you're on a time crunch again, just solve the main books that are going to be, I believe, Grey's Anatomy is good. Like the main books. You don't need to go into the... Because usually, as I recall, the file is like 30 pages long because they collect from multiple sources. But yeah, that's pretty much it. And for the Dr. Hassan's lecture, trust me, passed. Yani don't spend too much time on it. Don't prioritize it. If you have enough time, if you have time to spare, you can spend time on it and study it. But صراحة, it's most likely going to be passed. For any lecture for him? Generally, صراحة, yeah, even in F&D, I recall it was like that. Even in EndoReaper, you guys will have him too, and it's the same. Yani, we always collect past from finals, send one file. Okay, this is the question bank for this lecture. Thank you guys so much for sticking this far. here are our contact information, me and Ashaz. Please feel free to reach out. We're more than happy to help. Well, thank you guys so much.